Everybody, I think we should get started. Sorry for the delay. We had another meeting that went over a little bit, so we'll try to make up for time. I'll just talk really quickly. That should be it. Okay, I want to welcome you to the Enforcement Committee of the Medical Board of California. I'm Dr. Ronald Lewis. I'm chair of this committee. I want to ask all of us to turn off our cell phones to silent, and for board members, cell phones should probably be off the table. They tend to create some interference. You may notice that many of the board members have their laptop computers here at this meeting. The reason for that is that they're accessing material on the little zip drive instead of people like me who are old-fashioned to carry it in paper. So that's the reason why they have their computers up. This is an official business of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have a designated time on the agenda for public comment, and we will be asking for public comment on each and every agenda item. I ask that you be respectful of the need for us to conduct the board's business. Should anyone disrupt the meeting, I will ask that person to conduct him or herself in such a manner that permits the board to transact its business. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. And if for some reason I'm remiss and I forget to ask for public comment, please raise your hand and remind me, and you will be recognized. I would like to remind all speakers to complete a speaker's presenter's slip, so I can call you by name at the appropriate time on the agenda item, and we can record your name as a full and complete record for this meeting. Please give the speaker slips to Ms. Romero. Ms. Romero, could you appear? And she will take your slips during the meeting. The meeting will be available by teleconference, and individuals listening to this meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating by teleconference, please wait until the moderator has introduced you before you make your comments. There tends to be a little lag time, so to request to make a comment during the public comment period, press the *1. You will hear a tone indicating that you are in a queue for comment. If you decide that you no longer want to make a comment, press the # sign, and that'll remove you from the queue. Please remember to mute the volume on your screen during your presentation because it'll avoid the feedback. Assistance is available throughout the teleconference meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the board has limited the public comment period for individuals on the teleconference and those present here today to 20 minutes. Therefore, after 20 minutes, no further comments will be entertained. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be entertained. Please see Vang, who will be assisting me with receiving the public comments via teleconference during this meeting. So you'll hear C. Vang on the phone if there's any technical difficulties to try to assist you. I'll do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make a last-minute comment, but we need to ask you to please fill out a speaker slip after your comments so we have it for the official record. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to end today at 12:30, and therefore we may take some items out of order to accommodate this schedule. I would like to call the meeting to order now and ask Ms. Romero to please call the roll. Ms. Romero, the roll, please.
Dr. Kraus?
Here.
Mr. Liu? Here.
Ms. Shipsky? Mr. Serrano-Sewell?
Present.
Ms. Yaroslavsky?
Present.
Dr. Yip? And Dr. Lewis?
Present.
We have a quorum.
Thank you very much. On agenda item 2 on your agenda sheet, I have the following. I have no speaker slip for agenda item number 2. And is there anybody on the phone? Mr. Vang? This is for public comment items not on the agenda. Ms. Romero, do you have any for that?
We have
Okay.
no callers in queue.
Okay, very good. Thank you very much. Agenda item 3, approval of minutes from the May 1st, 2014 meeting. Thank you.
So moved. Second.
Second. Is there any public comment from those in the audience or on the phone? Mr. Vang?
Yes, we do have a comment.
Okay.
Dr. Kadisha Lang with the National Medical Association. Please go ahead.
Okay, Dr. Lang, go ahead.
Dr. Lang, your line is open.
Okay, go ahead. We're ready for a comment, Dr. Lang.
Are you able to hear me now? Can you hear me now?
Yes.
Yes, we can hear
Can you
you.
hear me?
Yes, we can hear you. Go ahead.
Okay, thank you. I'm Dr. Khadijah Lang. I'm the Vice Chair of Region 6, encompassing the 14 westernmost states, including California, of the National Medical Association, which represents the concerns of the nation's 50,000 African-American physicians and physicians of African descent, as well as their patients' well-being. I thank you for allowing me to once again address this board regarding issues that our members expressed. Firstly, there is a long-standing and persisting perception in the African-American medical community that the Medical Board of California has a negative bias towards them in its decisions. Our physicians repeatedly find themselves receiving longer, harsher penalties for accusations lodged against them as compared to non-African-American physicians facing the same or very similar allegations. The first assumption one might make is that, well, they shouldn't do anything wrong and they won't be in that situation to begin with. It is important, I believe, that this body realize how the board's process works and affects us differently, because statistics clearly demonstrate that the average African-American doctor makes significantly less money than their non-white colleagues, than their non-African-American physician colleagues, due to opening practices in medically underserved areas that have disproportionate percentages of patients on government assistance and Medicaid or Medi-Cal. Their profit margins often don't allow them the choice of hiring adequate legal representation to give them a fair defense once charges have been lodged, whether they are based or baseless. And this often causes them to be forced into settling on accusations that they are not guilty of due to the exorbitant cost of defense preventing them from being able to mount one. Were they choosing to not accept government-sponsored medical insurances, they would have a much larger profit margin and be able to hire appropriate legal representation to properly defend them against charges when those charges are false or baseless. But when a physician who has a very limited profit margin is facing charges that require a minimum of $50,000 from attorneys for retainers to begin representation, they're often forced to make the decision that, well, it's better to settle and still have a license to practice somewhat, though it would be restricted for life, than to go there and try to fight it myself without proper representation, and because of lack of knowledge of legal procedures, end up losing everything. And I think it's very important that people understand how this process works. Getting legal representation is only the first hurdle that physicians often face if they are operating small solo practices with minimal amounts of excess cash or savings, because they have opted to work in medically underserved areas and serve that community. It actually becomes a double punitive.
Dr. Lang, your time is up.
I'm sorry,
Your time is up.
I could not understand the comment.
The time, you've exceeded your time limit. You're on, talking about, I believe, agenda item number 9, which you were having later,
Let me
so.
just quickly summarize with 2 more sentences. Thank you.
Okay,
The
go
second
ahead.
point that we'd like to bring forward is that we think it's important for us to recognize the disproportionate impact on the African American medical community when their physicians are limited in their ability to practice or removed, because that community has such a small number of physicians in the first place. Capitation rates are often in some communities 1 to 4,500, one physician to 4,500, up to 6,000 patients, versus one physician for 900 to 1,000 physicians in many suburban areas. So removing one physician from those communities has a much more significant effect and impact on a community's health. And lastly, the medical board has a gender diversity issue that is sorely lacking in representation in at least 2 areas: African American physicians and physicians in general practice. There's only one pediatrician and multiple surgeons or surgical specialists, but no family practice or internist on the board, and their perspective is very important to the average citizen medical consumer.
Dr. Lang,
Consider bringing more of them.
you have exceeded your time, Dr. Lang.
Okay, thank you very much, Dr. Lang, for your comments, and the staff note that is under agenda item number 9. So you can
I'm
make.
sorry, I'm not understanding what you're saying.
That's all right. So we appreciate your comments, Dr. Lang. We're moving on to our next agenda item, but thank you very much for those comments, okay? Okay, let's go back to agenda item 3, which is the approval of minutes. We heard a motion to approve and a second. All in favor?
Aye.
Opposed? Okay, the motion passes. The minutes of the May 1st, 2014 meeting have been approved. We go on to agenda item number 4, discussion and consideration of the pain management expert reviewer policy by Deputy Attorney General Jane Zach-Simon and Kimberly Kirschmeyer, Executive Director of the Medical Board of California. Ms. Zach-Simon and Ms. Kirschmeyer, I'll welcome you to the speaker's table.
Good morning. Good morning. I would like to introduce Jane Zach-Simon. Ms. Zach-Simon was recently promoted as a supervising deputy attorney general in the San Francisco Attorney General's office. This office now has 2 supervising deputies. As most of you know, Jose Guerrero is the other deputy, supervising deputy in that office. Ms. Jane Zach-Simon has been handling medical board cases for 22 years, and she would really be considered an expert on our cases, specifically those alleging inappropriate recommendations of marijuana and also pain management cases. Ms. Zach-Simon was here when the issue of experts for pain management cases was actually originally discussed with the board, and I'm glad she could be here today to present this issue with me. Please direct your attention to your packet on pages ENF 4-1 to 4-4. As outlined in these memos, today we are seeking the board's approval to change the current policy for expert reviewers in pain management cases. Ms. Simon will provide the background and reason for this request.
Good morning. When we started talking about this issue a couple of months ago, it was hard to believe that we were back to an issue that came into effect. I think we had a task force that started in about 2000. And I remember Mrs. Yaroslavsky participating in the discussions, and another deputy and I were traded off going to task force meetings. And this was around the time when the board revised its guidelines for prescribing for, I think the term at that time was intractable pain. And some of the terminology has changed, but the issues are still there about what do we do to make sure that doctors are treating pain adequately, but also treating it appropriately and within the standard of practice. And there's always, no matter what you do and how many guidelines you have, that's an ongoing debate and a subject that I'm sure we will be back on in another 10 or 12 years. But one of the things that came up in the early 2000s was that pain management was really emerging as a separate and concrete subspecialty. But at the same time, all doctors were under increasing expectation that how do we treat patients with pain? Some of us have patients that we have been treating for a long time, and we do treat them, and maybe they don't need to go to a specialist at this point, but doctors were very nervous about providing adequate treatment for pain, and we were, from the medical board's perspective, we were still emerging from the age where we handled pain cases by counting pills and counting milligrams. So in an effort, when the board revised its guidelines, I think in 2003 or so, we also agreed that it would be a good idea to make sure that non-pain specialists had some room to treat their patients without fearing that they were going to be subject of a medical board investigation and disciplinary process, and being held to a standard of somebody who really was maybe even board certified in the area of pain management, but who was very highly trained. And all of this discussion coincided with a statute that required all physicians to obtain continuing medical education in the area of pain treatment as well. So the expectation was that the board adopted its policy where pain management cases are reviewed by two different experts. They're reviewed by an expert in the field of pain management, and they're also reviewed by an expert in the field of the physician who's under investigation. And that seemed like a good compromise at the time and a good policy that would allow patients to be treated and doctors to the freedom to treat while they were learning and getting the expertise necessary. But at the time, that was never intended to be a permanent policy, and it's some 12 years later, and we're still working under this cumbersome process where every pain management case that doesn't involve a pain specialist has to be reviewed by two experts in two different disciplines. And it's a costly and time-consuming process from an investigative perspective, and it is also a difficult legal situation because you have sometimes experts who are speaking essentially two different languages. And we believe that we've just come to the point where this policy has outlived the purpose for which it was created and has caused a lot more problems, and that we really are at the point in pain medicine where people who are treating patients for chronic pain, we're not talking about an emergency room visit or a patient who has a broken leg and needs pain medication to get through a period of acute pain, but physicians who are treating patients for chronic or intractable pain really need to be held to a standard of a physician who knows what he or she is doing in that area. And it's, we believe, time to start treating pain cases the same as we treat all other cases that are under investigation. And I did, in my memo, I did include a few examples. But if we have a physician who's treating let's say we have an obstetrician who decides to do cosmetic surgery, we would evaluate the case according to the standard of practice for a physician who performs cosmetic surgery. And there really is no longer any reason to treat pain cases differently than how we treat other cases.
Ms. Kirchmeier, do you have additional
Well,
comments?
I just wanted to say, so what we're asking for today is really just a change in that policy. As Ms. Zach Simon pointed out, we are treating these cases differently, and we do believe that we need to move on to where we actually have these cases only reviewed by one expert, and that expert would be in pain management, individual who's trained in that, and that would be very similar to how we treat all of our other cases.
Okay, so what, I've heard is there a motion to approve the change in expert reviewer policy to just require one expert reviewer?
So moved.
Okay, is there a second? Okay. Is there any public comment from those in the audience? And I have one speaker slip from Ms. Yvonne Chang from the CMA. Ms. Chang, you want to come please to the speakers table? Thank you.
Good morning. My name is Yvonne Chung. I'm with the California Medical Association. Thank you for allowing us to speak on this issue. We have some concerns with the proposed change. In discussing this issue with some of our physicians, going to just one reviewer who is a pain specialist, they believe sort of implies that only pain specialists should be managing pain. And I understand that this policy is limited to chronic pain. We're not talking about a broken arm, but it does raise some concerns because, as you know, the number of board-certified pain specialists is relatively small. So you do have a relatively small pool of them who would be available. Second, we have a lot of internal medicine physicians who would not be who would not be board certified in pain medicine, but they do treat pain in their regular practice. We have physicians who are providing palliative care, or geriatricians who are regularly providing pain management, but again are not pain specialists, and they have some concerns about being evaluated by someone who only does pain. And so our point is that the context is important. We do appreciate that having two different medical opinions can be very difficult, but I don't think that's a reason to discard one of them. You'll find this not just in pain, but in all kinds of specialties where you'll have difference of opinion, between, say, in pediatrics, you'll have a pediatrician and a pediatric subspecialist, and they may have a difference of opinion, but I think we need to figure out a way to make that work rather than just discarding one of them. And finally, I think this is an important enough change, and given the board's current work in revising the prescribing guidelines, I think if it is time to relook at the policy, this may be something the board may want to consider opening up to a stakeholder meeting, because as you saw with the prescribing guidelines, there was a lot of input. The pain community is not unified on this issue, so I think it would be certainly helpful to get some more information and perhaps change other parts of the policy too, rather than just changing a number in the existing policy. Thank you.
Okay, thank you, Ms. Jones. Appreciate it. Any other public comments from those in the audience? Any other speaker slips? No. Mr. Vang, are there any comments from those on the teleconference?
No callers in queue.
No callers in queue.
Dr. Lewis?
And then now we go to comments from the members of the committee.
So
Slofsky.
I would like a point of clarification. You okay there?
Yes, I am.
Point of clarification. I understood from the opening remarks that the object was that if it was a pain specialty doctor that was being investigated, a pain specialty expert would be reviewing the case. But if it was a regular, non-specific pain doctor, that the specialty that the doctor was in would be evaluating. And then I heard at the last sentence the reverse, and then I'm reading in the statement in Ms. Sack-Simon's report that your office is recommending the policy be revised to eliminate the two experts, which I agree with. Like in all other cases, require only that pain management cases be reviewed by experts in that specialty. So I'm not sure, and I'm not clear what you're requesting, because I would suggest that doctors that are prescribing medications for pain that are not pain specialty doctors should be reviewed by their own. Well, let's hear where you're going.
Under the current policy, the normal practice is that we have two different experts in
Right, I
pain
understand that.
cases. But if you have a pain specialist, for example, that the board is investigating, somebody who is board certified in pain medication or that is their specialty, they will only be reviewed under the current policy by one expert, and that would be a pain specialist, because that is their specialty. We don't
Right.
need to have two different pain
Right.
specialists. The change that we're requesting in the policy is that all pain management cases be reviewed by a pain management expert.
So that's the clarification I would like to hear, is that a doctor that is a non-patient pain specialty that is prescribing medication, and one of the issues of the investigation goes to prescribing, that doctor, regardless of specialty, would only be investigated by a pain specialist professional.
Correct.
And I
And
have
that's just the same way we do with all of our other cases. So if we had a individual who was doing obstetrics, let's say he was board certified in OB-GYN, and he went outside and he did a cosmetic surgery case, we're going to have an expert in cosmetic surgery. This is the same way civil cases are done. They go to the individual in what that practice and what that treatment was provided to that patient. That's the way we do with all of our other cases
But if
at
the
board right now.
OBGYN doctor was being investigated for OBGYN practice, you would have an OBGYN expert.
Yes.
So as part of the treatment plan of a doctor that is not a pain specialty doctor, I'm not clear as to why you would need to use pain specialty as the expert versus his own within or her own profession, an expert in that profession. I understand the one doctor. No problem with the one doctor expert review. What I have questions about is to why a pain specialty doctor versus a specialty doctor in the profession that doctor is to start with.
Because at that point, he's no longer practicing his internal medicine. He's practicing as a pain management physician in that regard.
Could I move on to other comments? Dr. Kraus.
Thank you. I'm sympathetic with Board Member Yaroslavsky's comments. And it's interesting that this issue comes to us because pain management is now a part of every medical school curriculum for all specialties, and all of us, including ophthalmologists like me, had to do our 12 hours of pain management. So on the one hand, we're saying now that pain management training is ubiquitous, we no longer need two experts. But on the other hand, we're saying an ophthalmologist may not be the appropriate one to evaluate me for my skills in pain management. There's some inherent contradiction there. So I would agree with Ms. Yaroslavsky's comment that if we want to make the process more efficient, that perhaps it's appropriate to have a like specialist in this circumstance review the case, because we're all skilled in pain management now. And if indeed another ophthalmologist would say Dr. Kraus was inappropriate because he was treating a patient with metastatic cancer for chronic pain instead of referring that for pain management, then that would be a reasonable criticism on the part of another ophthalmologist. But my main concern is that in medicine, I have observed that doctors, like all other people, may have biases. And regularly I see legislation introduced. Radiologists say that other physicians other than radiologists should not have radiologic equipment in their office. Board-certified plastic surgeons say no one other than a board-certified plastic surgeon should be doing cosmetic procedures. So specifically in a pain management specialty, where we don't have a plethora of pain management specialists, and there may be some bias, I would be a little bit reluctant to say that the one expert should be a pain management physician in this case, rather than to say a like specialist.
I'm also going to echo my two committee members' comments, is that we know now that the pain is the fifth vital sign, and so all physicians are responsible to assessing their patients' pain and pain control. And in a world where we do not, as Dr. Kraus said, have a lot of pain management specialists to go to, and especially some of the rural areas where there's maybe one in a major city, that we're now telling through this policy is that maybe I better not touch pain management. Maybe I need to tell that patient they need to seek a referral elsewhere. So I'm under the opinion that I think we're taking this a little too far now. I would like to see this brought back a little bit. Let's think about it before we we act on it, because I think we're going to shoot ourselves in the foot, and we're going to send a message out there that primary care physicians should maybe not be taking care of chronic pain, and I'm not sure we want to go that way. So those are my comments.
So I would also like to thank you for the comment, but I would also like to remind this committee, as well as the board members, is that the reason for the intractable pain discussion years and years ago was not only the overprescribing of medication, but was for the underprescribing of medication. And my concern by putting this back into a situation, it feels to me that we're going backwards, and I just want to be assured of the fact that within this discussion, that the standard of care is not going to change, that the expectation of anyone prescribing has to go follow through, even though you've got here on page 2, 4.2, you've got the standard of practice. And standard of practice, to me, I just want to ensure to me that it's the standard of care. They're synonymous, that they mean the same. My concern is that they might not.
They do mean the same thing.
They mean to the legal profession? Do they mean to the medical profession? Do they mean to the public perception? Maybe it needs to be enumerated as to the good faith exam, the medical record keeping, the treatment plan, and the follow-up and reevaluation as part of that discussion, so that we're constantly reminded of what is the expectation of a doctor, regardless of their profession, as to what they're doing. And my concern is that we're going to cause question. So, with this whole moving forward, as Dr. Lewis suggested.
So we're at a point where we have a motion on the table, as stated by Ms. Yaroslavsky. I think it's your motion?
Yes, it is.
What is the?
I don't know what the motion is. What is the motion you were asking?
Want to read the motion so we know?
I'm tired, so I apologize. I don't remember.
Motion was to move to
It was moved
one
to discussion, so it's
expert. So you just
we're
want to withdraw it. But I believe
I mean,
Ms. Zach-Simon has one other point.
Well, our point really is that it should be one expert and not two experts in disparate specialties. If the board is not comfortable having that be a pain management specialist, then as long as it's one expert and we have cases that we can look at and analyze and assess and make decisions based on experts that are speaking the same language, I think we could manage the cases a lot better.
I'm fine with the motion as it stands.
Yes, it's the experts speaking the same language is the key point, because as Dr. Krause says, that might not be the same depending on your level of expertise and training.
So we're not willing to define the expert at this point, but we understand, I think, the importance of having one expert.
Okay. Dr. Krause?
I would like to amend the motion to require that the expert be in a like specialty.
I would accept absolutely.
Accept that amendment, okay. And that you're the seconder of that, your second, okay. Any more discussions from board members? No? Okay, so we're up to a vote. So all in favor of
You have to have public comment because you've
Oh,
changed
yes, right.
you've changed the motion.
Anybody in the audience or on the phone that would like to comment now that we've changed the motion?
No callers in queue.
And no one in the audience? Okay, so then we're finished. Okay, all in favor of the motion as stated now?
Aye.
Aye. Anybody opposed? Abstentions? The motion passes. Thank you. Okay, now we're going to continue to agenda item number 5, and that's the discussion and consideration of the proposed amendments to the statement on marijuana. And Ms. Kirschmeyer, please.
I'd like to direct your attention to pages ENF 5-1 to 5-3. And as stated in the memo, in 2004, the board adopted a statement clarifying that the recommendation for marijuana by physicians in their medical practice will not have any effect against their physician's license if they follow good medical practice. The board's website continues to have this 2004 statement posted. However, in reviewing this statement, board staff believe that this statement needs to be amended as some of the information is misleading, and some does not comport with the current law. Throughout the entire document, including the title, is the phrase medical marijuana. Although marijuana can be recommended for medicinal purposes, the term medical marijuana is misleading, as there is no such thing as medical marijuana. This is an industry term, and board staff is recommending that this be clarified throughout the entire document. In addition, one other issue with this statement, which was brought to the board's attention during an administrative hearing, is that the statement asserts that an initial examination for the condition for which marijuana is being recommended must be in person. This statement contradicts the board's telehealth law. The initial examination must follow the standard of care and must provide an appropriate prior examination. However, at this time, there is no law that requires this examination to be in person. Therefore, the board is recommending a change to the statement to comport with the law. The actual changes are listed on the pages in your packet. Unless anybody has any questions on the changes, I'd like to ask for a motion to make the changes that I identified in your packet, unless you'd like me to walk you through them.
I have questions on this
Okay, let's-
specifically, so I don't know if you want to take a motion for the purposes of discussion, or if you want to walk it through first.
Dr. Lewis.
Your
I think it's okay if you go ahead with the discussion. for
Okay.
this, okay?
discussion.
Do you
Me?
have any-
Yeah, oh, absolutely.
You-
So you're looking to change the term medical
Well, we'll come
marijuana.
back.
Oh, is that okay? Dr. Cross,
Yeah.
please.
We're fine. You go ahead. Yeah, we'll take the public comments. Go ahead. Continue. I'm perfectly fine with
So
it.
just for clarification, okay, perspective?
It'll be important, yeah.
The term medical marijuana, you're looking to turn and change to marijuana for medicinal use
Medical purposes, yes.
or medical purposes, is that the same?
Yes.
Okay.
And throughout the entire document, that's pretty much the edit that we're making.
And the telehealth law, would you be more specific as to what the law states, please?
Yes, basically, the law authorizes an individual to be practicing in another area as long as there's informed consent. They do not have to be face-to-face, as long as they are providing an appropriate prior examination.
So as a point of clarification on this specifically, that's where I'm going, is so that a person that is making the recommendation for the medical marijuana does not have to be the same person making the examination and the treatment plan and the follow-up and the medical record keeping can be two different people?
It could be if it was with a physician. So if you had a physician that was providing an appropriate prior exam to an individual via telehealth, whatever that may look like, and that is according to the standard of care, that could be performed. So if they were at a clinic, for example, and they had a general practitioner there who was performing, or even a nurse practitioner, and that individual was doing the examination, and they were via telemedicine to an individual who recommended marijuana, that individual could recommend the marijuana, and that other individual that was in the facility could be doing the exam.
My concern specifically here is that we are giving license to the ability for a person to walk into a building and receive a recommendation from someone who has not done an exam, has not done a treatment program, has not maintained medical records, and has not done follow-up. So I want to make sure that within the document that you're recommending here, that is not what you're recommending.
And I would like to draw your attention to ENS 5-3, because Ms. Yaroslavsky, we have that same concern. However, the way it is written, it is not according to the law, so we need to make sure that we conform with the law. So what we've changed is removing the must be in person to what our law actually says, and it must be an appropriate prior examination and meet the standard of care. So if we received a complaint about an individual who walked into a facility and saw me, who was standing there with a cash register and was telehealthing via telemedicine to a physician in another spot, and that was not an appropriate prior examination according to a standard of care. So we would send it out to an expert, and that expert would opine on whether the exam that was performed was according to the standard of care and met the prior appropriate examination. If it wasn't, then we would take action against that physician, because that's what we do with all telehealth.
I'll wait for more discussion because I'm just not sure it's tight enough.
Okay, Mr. Serrano-Sewell, you had a comment?
Thank you, Chairman. You think this proposed policy is needed to provide clarity to staff?
No, I believe that this policy needs changed in order to comply with the law.
Okay.
As it currently is written, it does not comply with the law.
The statement doesn't, so
The
it needs to
statement
be.
does not, that it has to be in
updated.
person. It needs to be updated.
And can we just go over once again the need for the terminology, the words, medical marijuana, we're striking that, marijuana for medical purposes? It seems the same to me.
That, since we were going through and changing it, there is no such a thing as medical marijuana, and it's been brought to our attention on more than one occasion. So it's going back to the fact that it's marijuana that is recommended for medicinal or medical purposes. In that change, it's more of just a clarification rather than a comporting with law.
You're just getting people to say MMP or MMU and not marijuana for
Right, it's not medical marijuana. There is no such a thing as medical marijuana.
I've been consistent since I've been on this board.
Yeah.
It just to state again, because we're talking about a topic that I know generates discussion, that I do believe marijuana for medical purposes, or medical marijuana, however one wants to phrase it, does provide relief and care for people in pain and suffering from an illness. And so long as the physician comports with the law and giving that prescription, that should be honored. And the state should dedicate its resources to ensuring compliance with that, but it's an issue that the state struggles with, as does this board.
Dr. Kraus, please.
Alcohol has known medicinal benefit. I imagine a situation where it was unlawful to obtain alcohol without a physician recommendation, and every liquor store had a doctor sitting in the corner writing out recommendations for alcohol. We kind of dance around this with marijuana, and we're confined to the law as it is. But I would have nightmare in a circumstance knowing that all marijuana recommendations could be made by telehealth.
Exactly.
And I imagine a remote room filled with licensed physicians Skyping with people who want their marijuana recommendation, and that gives me chills. So if it is not current law that would prohibit that, then I would say that there's an obvious need for law or regulation that would prohibit that, and I would want the marijuana recommendation to be on the basis of an in-person examination until the state comes to its senses and makes this a recreational substance rather than one which can only be made available through a physician's recommendation.
So I can give you a little bit of legislative history, and I have to look to Ms. Simoes for the bill number, but there was a bill last year that was going through the process that would have required it. We had asked for, in our discussion with them, for it to say the words that it must be an in-person examination. That did not make it through the legislative process. As these bills come forward, that is something I think that this board feels very strongly about, and we will continue to try to get that put into legislation, because we agree with you, but at this point, what we have to do is as the complaints come into us, we have to take the action based on current law, and that's what we're doing with it being outside of the standard of care.
Yes, Ms. Shifsky.
As a former member of the City Council that grappled for 8 years on medical marijuana collectives, and by the way, there's no such thing as a dispensary, and people use that as a common language. It is really important because there are right now operators who are standing by, but operators who will put a room full of people and literally Skype to a physician who will then ask how many people have pain and then write the recommendations. So this is occurring. The in-person exams are not occurring, and the record keeping isn't occurring. And by the way, cities that have these ordinances are requesting that there is documentation of some sort, but it doesn't exist. And many of the physicians are actually being used to recommend a specific strength of marijuana when they make their recommendation, and that's a commercial decision because that's what the particular store sells. So I think we do need to do cleanup language as much as possible, and we even as a nurse practitioner, I have some reluctance that if you can allow somebody, and I don't believe the law allows a nurse practitioner or physician's assistant in this case, it doesn't even address other than physicians being involved in the good faith exam and recommendations. So perhaps at some point we need to get that cleared up as well. Because if it's assumed they can, that's going to open the floodgates to doing exactly what you just indicated, that you get a PA or a nurse practitioner or even an RN basically doing an exam and then somebody Skyping the physician and saying, I make that recommendation.
And again, that would go to, if we got a complaint about that, it would come to the expert to see if that was a appropriate prior exam from that physician, because that physician wasn't doing the examination.
Right, and can you
wasn't
clarify,
involved in
because
it.
it's, excuse me, it sounded like as if that during an administrative hearing, this issue, because you actually do put a pamphlet out about rules and regulations concerning
Yeah.
medical marijuana.
This is posted on our website, so.
Right. My students use it in class. But what I'm asking, what was raised in the administrative hearing that caused the concern?
It was brought up to us that that our records did show that it was in person. However, if you look at the law, it's not stated that it has to be in person. But that's what our guidelines was saying, and that does not comport with the law that's currently
My understanding
stated.
is the inference, and we've had some cases, my understanding, the inference is that because there is a requirement for physicians to make a good faith exam whenever they make a recommendation or prescription for medication, that's where the inference was made that you had to have a good faith exam before you could make the
You do have to have an appropriate prior examination. That's what the law requires. That's what the law actually states.
Okay.
Before doing anything. And we would treat for everything, for any type of prescription, whether it was a prescription for Vicodin, for an antibiotic, or for whatever.
So why are we limiting it and discussing telemedicine period at all? Why is that part of the discussion here?
It isn't, and that's why we're taking this out, to only state that it would be an appropriate prior examination and meet the standard of care.
Oh, that would clarify it then.
And that's exactly, if you look on page 5-3, that's exactly the language that we're putting in, because that is what the law states.
And I will add, Dr. Krause, Long Beach was actually disincorporated in 1896 because over alcohol, and then the way they got incorporated was to pass an ordinance that said you could have alcohol if a doctor wrote a letter.
That's
Or
Long Beach.
Or if you had a hotel less than 15 beds, and most of the city council members owned a hotel less than 15 beds, so, yes.
Dr. Krause.
It occurs to me that after we move and accept this modification, that I would also like to see this board take a position with a subsequent motion that would move to establish a board policy requesting legislation that would require in-person examinations for marijuana recommendations.
So we have tomorrow, under 21B, we will have Ms. Simoes up here talking about legislative proposals, and I believe that we can definitely bring that forward to you at that time under that correct agenda item, and we'll push that, see how the board feels about that motion.
I'll make a motion if you
Oh,
care
wait a
for.
minute, we have public comment from the audience. Dr. Sharon Levine, please. Board member.
She can't talk unless if you.
I think she can do that.
Or 6, she can, as long as we don't have a quorum of members in
She
the room.
can, not if we have a quorum. I'm willing to leave.
A board member can address the board if
I'm happy to walk out so you can have,
You don't get to leave.
Dr. Bishop, you get to leave. He's not on the committee.
Sharon Levine, board member, speaking in my role as board pedant. There are some other language issues, I think, that would be great to clean up if we're going to do this. The first is under the paragraph, these accepted standards are reasonable, are the same as any reasonable, prudent physician. The sixth thing.
What page are you on?
Page 2.
Okay.
Number 3, provision of informed consent, including discussion of side effects. I believe informed consent is a term of law, and I think that it should say is provision of appropriate consent, including discussion of side effects. In the next paragraph, the second line, as they would recommending or approving a medication. Marijuana is not a medication, and so that any other implies that it is a medication.
Right, okay.
So I think that should be changed. And again, the first paragraph on page 3, the physician must determine that the risk-benefit ratio of marijuana is as good or better than other treatment options. Again, so not implying that marijuana is a medication. Great, thank you.
Okay, thank you.
Do you want to also consider adding, I mean, we're not going to wordsmith, but the idea being that in conjunction with discussion with patients, in that last paragraph that you were mentioning? I mean, if we're going to get to wordsmithing on this, I mean, I've got some additional things, but we can talk about it afterward.
Well, we would have to have that change.
Okay, well,
because
okay,
this
so
is
if we're going to
posted
do
in
the,
board policy.
okay. So,
Go ahead and.
okay, so within
with
the
your
accepted
changes.
standards and the same, if any reasonable, okay?
Your, what sentence?
5.2, 5.2.
5.2?
Proper record, number 6, proper record keeping and maintenance thereof. But we find that's what's lacking in these standalone questionable entities. In number 5 on page 5.3, a physician who is not the primary treating physician, somewhere I put "and in conjunction with discussions with patient." I apologize. I have my notes and I don't remember why, but I've written them in. Thank you.
I think that's covered by 3. In order to provide consent and discussion of side effects, I think that takes care of the in conjunction with patients issue.
Okay. And the good faith of any exam, there's number 5, a physician who is not the primary treating physician may still recommend marijuana for medical use for patients' symptoms, as long as, but again, I just want to make sure that there's that good faith exam, there's the maintenance of medical records, there's the follow-up treatment plan, and that it's always listed, so it's in everybody's face. And Dr. Kraus, I want to thank you for your recommendation, because if you hadn't done that, I have to believe that if we cannot get the legislature to pass it, we can get the legislature to pass it. When they realize what's going on in their own communities, we have to do this.
Well, we're not.
Well, I would like to be participatory in helping that happen.
It's.
I don't know that we actually have a motion on the floor. And absent that, I would move approval of the statement with the language modifications suggested by Drs. Levine and Ms. Yaroslavsky.
I would second that motion.
Okay. We have any more public comment, either in the audience or on the phone?
No comments on the phone line.
Okay, so we have a motion and we have a second. All in favor of the motion?
Aye.
Aye.
Opposed? Abstain? The motion carries. Thank you very much. Okay, we're keeping pace. Exactly. So I'm glad you're sitting right next to me. So, okay, so now we move on to agenda item number 6, which is a presentation on the Physician Assessment and Clinical Education Program, PACE. Today we have with us Dr. William Norcross, the director of UC San Diego PACE program, and Kate Steipel, I guess I got the right, administrative director of the Phase 2 program, part of PACE, and Peter Bowl, who is the associate director of the PACE program. Their bios are in your packets. You can read them at your leisure. And I would ask Mr. Bowl, Dr. Norcross, if he is here, or Ms. Steipel to proceed with your presentation. Thank you very much for coming.
Thank you for having us, and sorry to inform you, but Dr. Norcross is not here. He had to attend a funeral today, so.
Oh, okay.
Yeah, so
It's okay.
Yeah.
Hopefully not.
You'll cover. part.
Okay, so we were asked to come here today to talk a little bit about a proposed redesigned assessment that we've been envisioning for the past year and are moving closer towards making a reality. And we've entered into some language, or I had worked previously with Susan Cady before she resigned on doing some language updates that would kind of reflect what our new assessment program might look like. And long story short, what we're doing is we're moving from the two-phase program that we have now to a one-phase program where the physician would complete the entire assessment in one foul swoop. So that's what this is going to talk about. And so the reason that we're changing the assessment is because we feel that we've gained a lot of experience and confidence in what we do and know that we can arrive at a decision of a physician's competence in a shorter period of time. And we are certainly sensitive to the amount of time that physicians spend coming to our program and traveling, and are trying to mitigate that as much as possible. And the other reason is that we are also striving to individualize each of our assessments as much as possible so that they're customized to the physician's practice or intended return area of practice. And so, and also while taking into consideration, of course, the reasons for their discipline. And one of the things that came out of the discussions I had with Ms. Cady was that we would be also changing some language. Instead of requiring the assessment to include components that touch on areas that led to their discipline, we may not do that in cases where a physician is no longer doing that. So to go back to an item that's been mentioned several times, an obstetrician gynecologist who is doing cosmetic surgery gets in trouble for cosmetic surgery, and then 4 years later comes to our office, but they haven't done cosmetic surgery in 4 years, and so we may or may not choose to continue to evaluate them. But as such, in the language now, we are required because it's part of the disciplinary guidelines. How is this assessment still going to be the same? Well, our core principles and values remain unchanged. We are here to protect patients and the public at large, and we are here to try to help physicians become better. And that's our goal, and that I'm not going to read you our mission statement. It's there on the screen, and it's in your packets, and it's also on our website. But basically, we have a goal, much like the medical boards, in public protection, and we will strive to do that. We're just trying to do a better job of what we do and be more efficient. So back to some more specifics. So how is it still the same? We're still going to have always a screening of physical and mental health. We're still going to focus on evaluating physicians in the 6 core competencies, of 6 core domains of physician competence that were defined by the American Council of Graduate Medical Education and ABMS, this is the American Board of Medical Specialties. After a physician's completed our assessment, they will still receive a final grade. It's in 3 basic categories: pass, a pass with recommendations, or fail. And where appropriate, we will recommend remedial education. And currently about 40 or 50% do get a recommendation for some kind of remedial education. So how's it going to be different? Well, as I said at the beginning, we're moving from the 2-phase paradigm to now 1 phase. And whereas the assessment currently is 7 days in length, we are trying to move it to about a minimum of 3, but sometimes may take a couple extra days. But our goal is to have it from about 3 to 5 days for each physician. Again, the focus will be on greater tailoring to their area of practice or intended area of practice if they are out of practice. And we will be using some of the tools that are now available to us through the UCSD Center for the Future of Surgery. We have a great simulation center that we have started using in the last year and will continue to do so as the simulation center grows and we become more familiar with what it has to offer. So how do we think this is going to be better? Well, I think importantly for the physicians who come here, it's going to reduce the amount of time that they're out of practice, reducing the travel time, which will save on travel time costs and loss of time in practice. And they will feel that they have received an assessment that is more germane to their area of practice and their specific practice. And I think the way that it's going to be better for the medical board is that it'll be easier to track physicians. You don't have to worry about have they come through phase 1, have they also come through phase 2. The amount of time that it will take us to complete the process will be reduced significantly. And the end result is we will be able to tell you if that physician is competent or if they are unsafe in a shorter period of time. That's it. We were told we had a short period of time. We wanted to leave it very short, and but we're here to answer questions that you might have.
Thank you very much. That was very good. I'm glad you were able to be here for that, because we have new board members, and some of the older board members need a refresher on what you're presenting, and now you have a new format, which sounds very, very interesting, and hopefully will provide us with our needed information. I'm going to ask for comments from our board members first, and then I have a comments, and then from the audience.
So will the cost be reduced as well?
At this point, I don't know for certain. Our goal is to try to make it as cost effective as possible, but the way that the evaluations will be created will be on a per physician basis. We will take into account their background, review a bunch of material, and we will look to see what components of the evaluation will be best for that individual, and that will be how the price will be created. And I mean, the range of prices, my general sense is I don't think there will be a significant change in price one way or the other. If anything, it might go down a little bit for some specialties and it might go up for others, depending. The things that will be costly to use are simulation, where you're having to buy cadaver parts and have the OR there available and things like that. But as we become more experienced in using that center, have a better idea of cost, we'll have a better idea. But the range, I think, is right now, I don't expect significant change in cost, but the significance for the physicians who come here is less time out of practice, which is a cost to them, and less travel time. So they're going to save there for sure.
So the issue of the simulation has always been the big opportunity.
Right.
For us as a board, we've had these discussions way back when to try and figure out how to determine competency of the medical practitioner. And I want to thank you for bringing this full circle to now evolving a whole new program by which we will know that the competency is much. We could never put a practice monitor really in an OR in a hospital for insurance reasons. So to check on the competency and the remediation tools you've offered and you've given us that, I want to thank you for that.
Thank you. By the way, that's a picture of UCSD's future for the Center of Surgery. So that's what it looks like, an OR. And they've.
Dr. Kraus.
Thank you for coming today. I'm still learning about all of the components of the board, and PACE is new to me, and I've learned from your presentation. Is your program used by other state boards, or does each state have its own PACE program?
No, there are approximately a handful of programs that do physician competency assessments in the United States, and they're few and far between. But we do receive about 50 to 60% of all of our evaluations from the Medical Board of California, another 20% from other state medical boards, and then 30% that would be comprised of hospitals, medical groups, attorneys, and self-referrals.
Yeah, I have some comments. I'm with the CDCR, so we do refer some of our doctors to PACE. But I have a question about outcome data, because we see they go through PACE and they pass. And do you ever look at down the road what happens? What did you change?
Yeah, I'd say that's the holy grail of what we would like to do. And I would ask the same question of residency programs that graduate their physicians to look at the outcomes. It's an important task. It's one that we have not figured out how to crack, though. We don't know how to crack yet. And I would say one marker could be low recidivism rates of physicians who come through our program, that's of course a weak marker. And I don't know, is that just the fact that because of the sanctions that they received, they are now acting as better physicians, or is it there's just too few resources to fully evaluate or keep a handle on what these physicians are doing in practice? But either way, this is an important idea that we've always wanted to be able to look at and haven't figured out how to successfully do that.
And I see here you have a category, pass with recommendations. Is it the recommendations that you will provide the additional remediation or recommendations, or you just give it back to us and then we have to figure out what that is?
We've always made a point to try to provide recommendations that can be achieved and not, esoteric and impossible for the physician to fulfill or for the board to be able to enforce. We've really made a point to work with the board on finding ways to make recommendations that can be enforced and the doctors can achieve. And the way that's different from what we're doing now is we've used phase 2 to provide some of the education while they're here. So the difference for us now is that we're going to be putting more effort on the front end of designing an assessment based on additional materials that we'll collect and asking questions about their practice and reviewing, so that we put that in the evaluation. But we will still have recommendations for education. We're not going to self-refer and require them to come back to our program. But if they would like to, we can put up custom programs. Those will be expensive, and that's why we're not going to self-refer for them. But if we have programs, or if they have, if we have a recommendation for a very specific area of medicine that might be hard to find otherwise, they could come to us, and that might help solve their problem, but they certainly aren't required to, and that was the goal for us, not to have it appear as though we're recommending they all return for some additional program.
Are there any other comments from members of the board? Any comments from members in the audience or on the, yes, please, did you fill out a speaker slip?
No.
Okay, please, after you finish, make sure you do for us, would you, for the record? Thank you very much. You can have a...
Yes.
Yeah, thanks for your presentation. As a matter of fact, I'm a PACE graduate.
Okay.
I finished the PACE program in 2008.
Ask him to come to the mic.
First of all,
It's better, if you could come to the mic, identify yourself,
okay.
where you're located, and so we can get it, so everybody can hear, including people on the teleconference, okay?
Okay.
Thank you very much.
I'm Dr. Anthony Jackson. I'm a PACE graduate from 2008, and I have some global concerns and actually fears regarding my experience of PACE. First of all, the cost is cost prohibitive, $15,000 for a general practitioner. Secondly, I finished medical school in 1975. And I was floored when one of the PACE exams was literally part 3 of the National Medical Board of Examiners. And I'd like to know, is there any weight given to a physician who graduated 30-some years ago, who has to take and pass PACE? I mean, just imagine, what if an attorney 30 years after graduating from law school had to take the bar again? Is there some weight given to those kind of situations? And last and most of all, I remember one of the questions for the general knowledge, the psychological evaluation. You know what the question was? The question was, who wrote the Faust? And the examiner was shocked and awed when I answered Goethe. Now tell me, for a part of a psychological exam, what type of relevance do those kind of questions have? And lastly, the use of PACE by the medical board. It's my understanding that PACE is first and formally to be used for competency and quality care assessments. But yet the board has been known to require physicians to take PACE for getting behind or delinquent in their taxes, or for a DUI that was overturned. And I believe Judge Farley from the Sacramento Superior Court has chastised the board in the past for this use or misuse of PACE. What's PACE's position with regards to these type of problems?
Well,
Dr. Jackson, are you,
This is not,
Yeah.
this is not a question answer.
thank you, Dr. Jackson, for your comments, okay? I think if you could briefly, within a few seconds, 30 seconds, just briefly address where you are now versus where you were, we could,
yeah.
some conclusion, that would be helpful.
Sure.
Briefly.
First point would be the general practitioner's cost today is $12,500, not $15,000. I don't know what it was when he came at the time. Either way, we do realize expense is a big reason that it's hard for physicians to come, and we're hopeful that this new arrangement will save money for physicians. With regard to the Faust comment, I have no idea. Oh, sorry, just our presentation. Yeah. Again, just to summarize, our goal is to become more efficient in what we do, make it take less time to determine competence, and hopefully, decrease the amount of time it takes for physicians out of their practice to come.
Thank you very much. And if you will maybe remain after we adjourn, there might be other questions, maybe from board members, other people. That would be great.
Okay.
Okay, thank you very much for your presentation. I appreciate it. Okay, now we move on to agenda item number 7, which is the presentation discussion on utilization review. Ms. Carrasco, please come to the speakers table. Thank you very much. Later on, that's right.
Good afternoon. In April 2013, staff made a presentation before the Enforcement Committee on how the board processes complaints involving physicians who conduct utilization reviews. It has always been the board's position that performing utilization reviews is considered to be the practice of medicine. However, the Central Complaint Unit routinely referred these complaints to either the Department of Industrial Relations, Division of Workers' Compensation, or the Department of Insurance to address the patient's appeal of the decision made by the physician performing a utilization review. The Enforcement Committee felt it was appropriate for the medical board to review complaints regarding utilization review, and a change in protocol was implemented in May of 2013. I'd like to report the findings after the board's evaluation of utilization review complaints. For approximately 18 months, during this time period, the board received a total of 40 complaints regarding the physicians performing utilization review. The Central Complaint Unit typically receives 7,500 complaints in a year, so this complaint type represents a small subset of complaints received. Complaints received about utilization review fell into 2 general categories: those performed in connection to workers' compensation claim and those performed by insurance companies. When a case involves workers' compensation, by law, a utilization review must be used to decide whether or not to approve medical treatment. The patient's case is reviewed by the claims administrator to ensure that the treatment recommended by the physician is medically necessary.
I can go dance.
However, a decision to deny, modify, or change the patient's treatment can only be made by a physician who understands the type of injury or illness the patient may have and the treatment being recommended. If the patient or his or her representative disagrees with the outcome of the utilization review, then the independent medical review can be requested. As you can see, 61% of the complaints received related to workers' compensation cases pertain to allegations involving quality of care. Board staff contacted the Department of Industrial Relations, Division of Workers' Compensation to gain a better understanding of their utilization review process and found the following. Treatment standards are defined in a regulation. There is no requirement that utilization review physicians be licensed in California. California Code of Regulation, Chapter 4.5, Section 9792.6V allows the Division of Workers' Compensation to utilize physicians licensed in any state or the District of Columbia to conduct the utilization review. Insurance companies review the recommended treatment, for a patient. If the treatment is denied because the insurer determined the treatment is not medically necessary or was experimental, the patient is first referred to their medical insurance's grievance process. If the insurance company upholds its decision or is delayed in responding to the appeal and grievance, the patient or his or her representative may request an independent medical review through the Department of Insurance. Only decisions regarding a disputed health care service related to the practice of medicine not involving coverage issue are qualified for the independent medical review program. According to the analysis performed by staff, 50% of the complaints received in the Central Complaint Unit related to the insurance company cases pertain to allegations involving quality of care. The Division of Workers' Compensation with the Department of Industrial Relations and the California Department of Insurance utilize an independent medical review performed by a physician to determine if treatment being recommended is medically necessary and/or whether an appeal will be approved or denied. Both agencies provide a process when a decision to deny, modify, or change a patient's treatment is appealed. The person who receives a letter of denial in most cases also receives instructions on how to appeal the decision. As shown earlier, 58% of the utilization review complaints received allege the review resulted in a decision that impacted the patient's care. The Central Complaint Unit processed these complaints as quality of care issues and attempted to secure any information relevant to the case and had a review performed by the medical consultant. In all cases, the consultant found no evidence that the opinions reached by the reviewer were inappropriate or outside the standard of care. Staff is suggesting that the board continue performing preliminary analysis of complaints involving utilization review with emphasis on those related to quality of care. If the case involves a utilization review issue that is not regarding the quality of care provided by a physician, it is suggested that the Central Complaint Unit staff advise the complainant to pursue their concerns through the grievance process or appeal process that is identified in their denial letter. That concludes my presentation. If anybody has any questions.
Are there any questions from members of the board? Ms. Shipsky, please.
I think we were kind of sidebarring a little bit ago. I think the board at some point might need to make a recommendation for legislation to require that physicians in worker comp review have to be licensed in California. I know I've represented physicians who are having great difficulty sometimes getting paid for taking care of these patients, and the difficulty is that it's been a nurse reviewer locally who has said no. And then when the review comes, it's from a physician that either is not in the same specialty or they're out of state. And so the frustration, both for the provider and I think for the patient, is there is no recourse. I mean, it's very difficult. I know the workers' comp board says go to them, but there's no recourse. And some of these utilization review companies just automatically deny a request for care and treatment, because they figure that it will wear down the person. So I'm hopeful. I know that in managed care, you have to have, I believe the physician has to be licensed in California and has to be of the same specialty when they review a claim and deny it. So is there any way we as a board can make a recommendation that the physician who does utilization review for workers' comp?
There has been attempts, and they've been vetoed, so.
We tried again on the basis that it would be protective of both the providers.
I can tell you there have been two attempts under two different governors. They've both been vetoed, and Ms. Mose can also elaborate on that, but we've tried.
Well, we should try again, because this is really a difficult situation.
Yeah.
And the board has supported both the bills that were vetoed. We've been supportive of any measure that comes through like that, so.
Okay. We can find a good sponsor.
Any more board member comments? No? Comments from the audience. I have Mr. Steve Catolica. I got that right. Welcome. You can state your name again and the place from where you come.
Yes, my name is Steve Katolika. It's my privilege to be the Director of Government Relations for the California Neurology Society, the California Society of Physical Medicine and Rehab, and the California Society of Industrial Medicine and Surgery. We were the sponsors of those three bills that were vetoed, and we appreciated at the time the support of the board, and we would seek it again. We have not given up that issue. It was an administrative decision on the part of the Division of Workers' Compensation to interpret the ambiguity in the law to essentially pass on the physician's licensure and where it should be. But that's really the nature of part of the questions, but that's not why I'm here.
So that doesn't go against his 3 minutes?
Yeah, right.
Yeah, thank you.
Right.
As a matter of
Reverse
fact,
time.
I will guarantee you that's going to go off. In 2013, we were, I think, helpful in clarifying for the board that the complaint that Assemblyman Henry Pereira forwarded, asked you about and asked the questions about, was actually not about the process of deciding medical necessity, but because the injured worker was actually harmed. And that was the turning point. All those statistics have nothing to do with harm. We're here to say that we believe that there's some education that needs to be done, and we as organizations are attempting to do that and will continue to educate the patient population as well as the physicians and those occasional attorneys that end up being in the mix somewhere, that it's not the process. You folks cannot do anything about the process as flawed as it is, but rather that you need to be able to discern when harm has taken place, and they need to communicate to you that that's the case. There's one that you're going to get a complaint, and I know that you've gotten several, but I know that you're going to get a complaint about an authorization for a spinal injection that included authorization for the procedure, included authorization for the radiological component, but did not authorize the IV sedation that sometimes needs to go along with it. And the surgeon was not able to provide that care, because when they get the person on the table, if they're anxious and need help, they're going to need to sedate the person, and yet they could not. That injured worker was harmed to the point where they needed care subsequent to that process that they should not have had to experience. That's what needs to be communicated in the complaints. We understand that. I don't think the public does as well as they should. And so we're here, as I said, to tell you that we're going to do everything we can for that education process. But please, in the meantime, do not dismiss what's being given to you as simply complaints about the process, because it's easy to complain about the UR and IMR process. We're convinced, and there's a case going up, that in fact the IMR process, the way that it's in labor code now, is
Your time is up.
Unconstitutional. So we will be working with you. Please don't turn a blind eye to this. Thank you.
Thank you very much for your comments. Appreciate it. Any comments from members or people on the phone, teleconference? Anybody?
Yes, we do.
Okay. Please state your name.
It's from Dr. Kadisha Lang with the National Medical Association. Please go ahead.
Okay, Dr. Lang, go ahead. We can't hear you, Dr. Lang.
Okay, can you hear me now?
We can hear you now. Go ahead.
Okay, thank you. I apologize, the timing of this is a little bit late. I was trying to get in right after the discussion on the PACE program, and I just wanted to put it to your attention that if the genuine object of the board and the PACE program is to try to help re-educate physicians to give better education and know how to properly take care of patients if they have been found to be insufficient or inadequate in some area as a result of their interaction with the board. I think that something that should be looked into is having a part of our medical fees that we pay to be licensed include the cost of a PACE program, because the cost, once again, is quite prohibitive. The cost of attending a PACE program when a physician is recommended to go there as a part of their settlement can run, I'm told now that it's running between $5,000 to $12,000, in some cases more, plus they've got to leave their city, they've got to pay for housing and food and all those things while they're at the program. So I'm thinking that perhaps something that should be done in order to make it more accessible for physicians to have that as an option to consider is make that a covered cost. We are paying licensing fees every year. Let the cost of that program, if it's really going to try to benefit patients by improving the quality of their physicians, let that be included in our licensing fees, because the cost is prohibitive for many people.
Okay, thank you very much, Dr. Lang. Appreciate it. And let you know that the staff from PACE is in the room. Okay, moving on to agenda item number 8, and there is going to be an update of the transition of staff to the Department of Consumer Affairs. Mr. Gomez, welcome back. It's always nice to see you.
Good afternoon, Chairman Lewis and members of the Enforcement Committee of the Medical Board of California. I'm Michael Gomez, Deputy Director for the Division of Investigation Enforcement Programs for the Department of Consumer Affairs. I want to give you an update today on the transition of the Medical Board investigators to the newly created Health Quality Investigations Unit of the Division of Investigation. We are now through the first quarter of that timeline of July 1st, and I'm pleased again to tell you that it has gone very smoothly, and with the help of Kim Kirkmeyer, the Department of Consumer Affairs continues to review the budgets, review and have discussions with your executive director regarding the costs, if you will, as this transition is going forward. And so we're sharing that information where unfinished business has not been concluded. We try to resolve those as soon as possible. And to Kim, she's got a pretty good eye on the budget. An example that we had recently was the coding of rent space, and a couple of our field officers, you were being charged for it, and it should have been us being charged for it. In the personnel area, I wanted to tell everybody that I take great interest in our staff, and on August 8th, the director and I and the chief deputy director held a all supervisor meeting for all HQIU leadership team members to hear and discuss concerns they had or challenges they may be seeing that they could share with us, and it went very well. I think it implanted in the executive office not only the importance of our work, but the dedication of the employees of the Health Quality Investigations Unit for the Department of Consumer Affairs. In time, we have also tried to make the issue of equity on the Investigation and Enforcement Unit side and the HQIU side, now former medical board employees, so that the equipment issues are resolved and there is equity in the operations, if you will, in terms of equal treatment across the board. So, Ms. Yaroslavsky, I think I mentioned to you last board meeting that the vehicles will be in for the supervising investigators for HQIU at the end of this month, and to also notify the Enforcement Committee that we've had some new technology improvements coming to HQIU as well. In March of this year, the California Department of Justice approved the Division of Investigation to have mobile access to the California Law Enforcement Telecommunications System. So we will be buying and providing to all the investigators on the HQIU side mobile access, wireless access now to CLETS, which is a wonderful tool in the field investigation. As you can probably visualize, that it's no different than that terminal you'll see in a patrol car. Mobile data terminal, and that is what we're beginning to share with the HQIU investigators and our peace officers. As stated in the previous meetings, I want to provide this board and the Enforcement Committee with data and comparable data in terms of the improvements that we are attempting to make and looking at case aging across the board. I have some rough numbers that don't give me any great concern. We seem to have a little bit of a bubble approaching the year cases, but that, as I said, is our rough numbers, because I cannot run reports out of breeze right now. We are attempting to correct what's called the E229 report. We have some logic and behavior patterns that aren't accurate reflecting what those numbers should look like when we compare them with actual figures in the field. So there are some behavior issues that we are reconciling with Breeze to get those reports corrected. And I know that Kim and I have had the same issue regarding the standardization of those reports. But I'm confident we'll get there in standardizing those reports. In the rough data that I have looked at, and just to remind the Enforcement Committee that we are using Excel spreadsheets at each district office to track the case aging by investigator, by district office. So we know that what the numbers look like. The problem is that the stats that I have today are the stats that were compiled at the end of last month. So they're 23 days old. But in looking at them, there is no major increase in the case aging when I look at all the sequential data points of 1,900, 800, 700, 600, 550 days, et cetera. There's a small bubble in the 365-year-old, but we have instituted a goal now to look at those 365-year-old cases and instituted case aging councils at each field office. Chief Threadgill and retired annuitant, your former Deputy Chief of Enforcement, Laura Sweet, are now going out to the field and are going to reinstitute those case aging and those case reviews so that we're on top of that. Regardless of the reporting data that we have, we can get in Breeze, we want to make sure that those case aging issues do not become uncontrollable. But I feel confident that we can do that through the processes that we have in place. So our goal is to decrease that number and begin to look at a report that we can hopefully provide the Enforcement Committee and the Medical Board at our next meeting that maybe is a little more accurate than the dated numbers that I have. I also wanted to give you an update on VE. Regarding the VE program, at the last board meeting, I reported that the Division of Investigation was following the July 2011 version of the Vertical Enforcement Manual that was agreed upon by the Medical Board of California and the Attorney General's office. And I also reported, Ms. Yaroslavsky, if you recall, that we were going to have some meetings, and those meetings have occurred. We've had 3 meetings to date. The meetings are structured. We have agreed upon agendas. We have actually completed an initial draft of the first, what I would call the first stages of the Vertical Enforcement Manual that relate to the definitions of vertical enforcement under the government code, the vertical enforcement team, and we've added a new component in there regarding the VE team as it relates to the medical consultants. The medical consultants prior were not included as defined team members in the vertical enforcement manual. We are looking at, we've just have agreed upon, I believe, on the disagreement resolution, but we still have a ways to go. Our next meeting is next Wednesday. We're meeting hereafter every 2 weeks and hope to have a final product or a final draft by the second week in December. I'm very confident in the process that we are following, that we literally have put everything on the table, so we can glean from lessons learned, what we've experienced, what we're seeing, if there are efficiencies or there are better ways to do business in terms of our partnership with the Attorney General's office, with the case aging and the roles of the investigator, the roles of the prosecutor, if you will, and also the timetables that we should be looking at in terms of the respective roles in this VE process. The last thing I want to, because I know time is short for the committee, is that I am extremely pleased with the transition and the way it has gone. I'm also very supportive of the process that we're using. Our VE manual work group consists of your executive director, myself, the director of our department, our chief deputy director, our legal counsel, and Deputy Chief Laura Sweet, and Senior Assistant Attorney General Gloria Castro and her staff. So we have a lot of good minds that are working on this, and we have, I thank Gloria for being open for all these discussions, and we're looking forward to completing this process as soon as possible. If there's any questions, I'm pleased to answer those.
Okay, thank you very much for the presentation.
Wait a second.
No, I'm getting on to you, but any comments from members in the audience? Any comments from members on the teleconference? Telephone?
No callers in queue.
Okay, now comments from members of the board, of the committee. Go ahead, Ms. Yaroslavsky.
So, Mike, I have a few questions. Sure. We heard a whole lot, but we heard a whole lot of, I'm not sure what we heard a whole lot about. My concern is that Breeze is still not, you're not able to access Breeze. Do you have a date time frame when that's going to be working?
Kim, correct me if I'm wrong, we talking December? I think that's what the Breeze user group came to, that the modifications to that report would, yeah. Right.
That report doesn't work for your statistics, so.
It's in your report, too.
It is. It's in my report. I was just notified actually yesterday that our staff who have been working on these reports, their information that they are working on, the database that they have been using, unfortunately, we may have some issues with them using it. We're working with the department right now to see if we can get in to get the information. We've been working on these reports. We hope to have them by the end of the year is what I believe in my report. And that's, unfortunately, everything that we look at has to go back in almost and be manually touched in order to bring the information up to where we can even run the reports. So that's kind of what we're looking at. The report that Mike's talking about, the E229, we were able to run some reports, some preliminary ones, and then take it from what the E229 report was and then turn it into how we would normally do it, because the 229 isn't the way we've used it for our reporting. And we actually, Mike is right, it is actually at the end of last fiscal year, the number that was at the end of last fiscal year was 245 days, and for the first quarter was 235. Now, I cannot sit here and say with 100% assurance that those are the accurate numbers, because we still are working out to verify those numbers, but I can give you that number. It was 245 at the end of last fiscal year and 235 at the end of this first quarter.
So that's an improvement. Yes. So the next thing is that the Excel spreadsheets that are going on now in the offices, that will give you a better definition of the timeline and the timeframes to make sure that that's happening?
It is, yes. It's a great management tool for us to do that. When we look at the individual investigator workload and the investigator time cycles, we have a pretty good handle on that. The issue is, when I'm in Sacramento, I can't grab that at a moment's instance because they're spreadsheets. They're only for the time at the end of the month which we compile them. So that's why we're sending Renee and Laura Sweet out to the field so that we can be on top of those cases. So we're looking at those case reviews, those case review councils, and that we begin to look at sending reports that back to the field when we see the bubbles approaching 365 days, we need to notify.
You're catching them.
We have to, because if we don't, what happens is we have bubbles. We have volume bubbles that if you don't catch them earlier on, you're going to be caught off guard. And we need to catch those as soon as possible.
So what I'm looking for is just, the last thing I would like to ask you is, in the past, when you didn't have this oversight,
right,
we were able to hold our staff's feet to the fire. They reported to us automatically. We knew exactly what we were asking questions about. We had the information at our fingertips.
Right.
You've given us a report, but I haven't heard anything that, other than we have a few bubbles.
Well, I can tell you
what is a good report going to sound like from you, and what is a poor report going to sound like? What do we need to be worried about that I'm not going to, I want to make sure we're not reading about it in the front page of the newspaper that we're holding up stuff.
I think there's two things. That those priority cases, those cases when we're working with the Attorney General's office, those PC-23s or those ISO cases, that those aren't recognized at the front end as urgent cases. Those are things that are going to hit the paper. Those are not case aging per se, but they're public safety issues. The second issue is that when we start seeing cases that should have moved along efficiently and we're not on top of it, and we should have been on top of it, I think those are the things that get in the paper as well. But we look at the category of those cases. We look at the, if you will, the priority of those cases as well, and working with the AG's office and the lead prosecutor, try to develop, what comes first. But I wanted to do this. I want to tell you that in assessing the raw numbers and assessing the numbers we have put together, I can tell you about pre- and post-transition levels of production. In comparing the first quarter of fiscal year 13-14 with the first quarter of the fiscal year, I noted there have been 74 fewer cases assigned to the field. This is largely attributable, I believe, to the implementation of the non-sworn complaint unit, which is now as part of the Consumer Protection Enforcement Initiative, the non-sworn unit that now resides at the medical board, which now handles the less complex 801 cases. Okay, so those 801 cases aren't coming to HQIU, I believe. As for cases closed last year, we had 208 cases that were closed as of October 1st. This year, 203 cases have been closed. Last year, 19 cases have been referred for citation and fine or public letters of reprimand, and this year, 20 cases have been referred. So last year, 19, I'm giving you kind of a summary of what I put
Workload is
together.
similar? What you're telling me is the workload is pretty similar?
It's similar, but one of the things that...
Improving or similar and not improving?
I think there's some improvements, but one of the mitigators in that is that this is the year of retirements. Again, for the peace officers, we're losing. We just lost Laura Sweet. John Harai, the Soup 2 out of South, is retiring December 30th. Marianne Eckhoff is retiring December 30th. And we've had people leaving to other agencies as well. So we do have a vacancy rate that I can see there's a bubble. And so that's why we're trying to catch these 365 case aging issues early on.
Mr. Gomez, let me move on for just a couple of pertinent questions. The timeline between the HQES and the HQIU, that timeline we don't know. That's a part of this puzzle, this equation between the two.
Right.
And I don't hear that part.
And that part is the discussion that Gloria and I have had regarding the how do we my count versus AG's count.
Right.
And so how do we matriculate the data between the two agencies? Because I just explained that I'm putting together spreadsheets at the end of the month.
So maybe you'd need to take a date, and as of that date, even if it's not this month, maybe it's 3 months ago, maybe you need to come up with a date that you're going to have consistent on both sides, that you can compare real and get to where Dr. Lewis is going.
Yeah, because we have no control over that.
Right.
But that's a big part of when we get
yeah.
the information back to the medical board. That's the time.
Right, and that is one of the concerns that I think that when you look at the administrative justice system, that when you look at the cycle times from the intake to the investigative stage to the referrals to what I call the adjudication system, there is some disconnect there.
Yeah, there is. Okay. Yeah.
Dr. Lewis, I just want to let the members know that it really all rolls back to the fact that we can't get reports out of Breeze that we need, because everything that we would need to compare to what Ms. Castro has are the reports that we need to get out of Breeze. I've asked for, as of November 1st, the pending cases that are at the AG's office, so I'm going to see if this is able to be achievable. I think with what happened yesterday, that may impact me getting that, but I'm hopeful that the department understands the importance of these reports to us and will assist us in getting those. And so that's really where everything for poor Mr. Gomez, as well as you as board members and our executive staff, it all hinges on those reports, and that's what we're trying to get. So. And
the production releases for these were supposed to have been almost completed in November, right?
Mm-hmm.
Are you on track with the production releases for Breeze?
I think we pretty much.
You done with those?
The issue that I have seen is the standardization issue of the reports.
Right.
I think the standardization issue, which we are addressing, we're working through that. And we're trying to get that completed by December. Okay, but go ahead, Kim.
Those changes that are going to be made are not the ones that we need for our reports, because again, we're the ones working on our reports at the staff at medical board. So the changes that are being made in Breeze are more for the production part of Breeze. It's not for the reports.
Not for the reporting part, okay.
There's the one report that they're working on, but other than that, that's it.
I think next time if we could see numbers on a piece of paper.
I would agree.
I
that would
think
be
that
very
is so helpful.
We're going to attempt to do that through hook or
Okay.
crook. We're going to try to do that. I mean, we have, in the field, we have our own case management information. It's just not live in terms of what you need.
But it can even be rough that you produce because some of us are very visual.
No, I get you,
versus
Doctor.
auditory.
I get
So
you.
me. Okay, thank you. Any other quick comments or thank you very much. We'll see you at the next
One
meeting.
thing, Dr. Lewis,
Okay.
I do want to just inform the Enforcement Committee that the department does and still continues to invest very seriously in the BREEZE project. We are working to correct a lot of these, and there's a lot of lessons learned in this. It's a huge project, and we are committed to making it work, and I have been directed to attempt to get these enforcement reports corrected for the purposes that I need them for in the boards. Okay?
Well, we don't envy you. So,
good job.
Thank you. Thank you very much for your report, and we will see you at our next meeting, I'm sure.
I know you're visual.
Yes, visual, please. Thank you very much.
I am as well, Mr. Gomez. It would make my
Yes,
life a lot
she is
easier to
as
see
well.
something on paper.
Yes.
Yes, right. Okay, thank you, Mr. Gomez. So now we move on to agenda item 9. I know we are well over our time allotted, so we really have to move on very quickly. The next is disciplinary action demographics. Ms. Kirschmeyer and Ms. Robinson are now presented at the speaker's table. Thank you.
Okay, we'll try to make this quick. At 2 prior board meetings, we actually had public comment stating that there were racial differences in the board's disciplinary action. The implication was that certain individuals received more discipline or more significant discipline than others. In order to determine if these allegations had basis, the board staff looked into this issue. Before I have Ms. Robinson go over the chart and the information that has been gathered, I would like to just discuss some information that is important in the process. It is important to point out that the board only takes action on complaints that we receive or that the board otherwise becomes aware of a violation. The board receives complaints from a number of venues, including patients, patients' families, licensees, other state or federal agencies, mandated reporting, newspaper articles, law enforcement, and industry associations. From time to time, during an investigation against another physician, the board may be alerted to possible violations by another physician and may open a complaint. In addition, during the course of an investigation, the board may identify other patients who had civil cases against them, against the physician being investigated, and may open a new complaint on that patient. However, outside of this, the board does not randomly or with cause go out and inspect a physician's office and look for complaints. The board cannot review a patient's records without authorization or subpoena, which would require authorization via good cause, and therefore such inspections would not be a good use of the board's resources. Other state agencies, such as the Department of Healthcare Services that oversee Medi-Cal, can do this. However, the board cannot. The other issue that needs to be discussed is that the board does not know the ethnic or cultural background of a physician when it first receives a complaint. Out of approximately 7,500 to 8,000 complaints received annually, almost 6,000 of those complaints are closed with no further level of action. Although the board requests ethnic and cultural background information on physicians, this information is listed on the board's licensing system, and staff does not have that information during the complaint review. In addition, a large percentage of physicians do not submit this information to the board, as it is actually optional information. Once an investigation is initiated, the board's investigators would be aware of the physician's ethnic or cultural background, specifically when they interview the physician. However, no action can be taken specifically on quality of care cases unless an expert opines that there was a departure from the standard of care. In addition, the Attorney General's office must agree that there is establishment of a violation that meets the level of clear and convincing evidence. Once that decision is made, the executive director must sign the accusation to pursue disciplinary action. Once the accusation is filed, the matter proceeds to either hearing, stipulation, or default. A final action cannot be taken without the review and approval of the board members, and decisions do not indicate a respondent's ethnic or cultural background. Unless the matter becomes the comes to the board through an oral argument hearing and the respondent physically appears before the board, the ethnic or cultural background is unknown to board members. Only a very small percentage of the cases go through the oral argument process. All of this information is important for the board and the public to understand as we proceed to explain the information that has been gathered. I would now like Ms. Robinson to proceed with the findings from the statistics gathered. Ms. Robinson is the board's research program specialist and is the one that deals with all of our data at the board.
Thank you, Kim. Good afternoon, Chair and members. Please refer to pages 9-1 and 9-2. 9-2 was just added. I think Paulette probably brought it around. It was posted on the board's website, and there's also copies in the back. This information is regarding the ethnic background data that's being provided. The data shown on these charts were gathered by the board's enforcement data and the board's physician surveys. If you'll refer to 9-1, the ethnic background data displays the complaints, investigations, and discipline for the 3 fiscal years 10-11, 11-12, and 12-13. With regard to the ethnic background, the percentages shown, for example, in ethnic background that is other ethnicity, moving from left to right with the fiscal year 10-11 starting, there was 4.3% complaints. In 11-12, there was 4.5% complaints. And in fiscal year 12-13, there was 4.5% complaints. And that's complaints based on the total number of complaints that were closed. If you look at the same ethnic background for other with regard to investigations for those fiscal years, they're 4.1%, 3.9%, and 4.5% respectively. The discipline for those fiscal years shown for that other ethnicity show 2.3%, 4.6%, and 3.9%. With regard to the chart on 9-2, we actually took the other ethnic 3.9% that was shown for discipline only for fiscal year 12-13. And looking at that, it shows the total number of discipline for other ethnicity was 15. That's the grand total. Of that total, there were 4. The penalty imposed, 4 of those were for probationary years 1 through 3. There was also 4 for probation for 4 to 5 years. And there was 1 PLR. There was 2 revocations and 4 surrenders. We only provided the fiscal year 12-13 data because staff just started tracking this in a spreadsheet form. It is very, very labor intense, and I'm so glad staff started doing that. We were able to look at the severity of the imposition and compare it to the enforcement data, put those 2 together, and was able to provide this chart. So moving forward, we will have this data. The number of So in developing these charts, I consulted subject matter experts to determine how better to go about gathering data to answer the question, is there racial disparities imposing disciplinary actions by the board? From the data on both of these charts, you could see that decline to state, no response, and no survey found shows high percentage of physicians that do not provide their ethnicity on the board survey. For some physicians, they actually indicate multiple ethnicities on the survey, as shown in the charts as multiple entries and multiple answers. Looking at chart 9-2, you'll notice under the decline to state, no response, no survey, for probationary licenses, there's 21, and that's because there's no survey done when you're applying for licensure. As Ms. Kirkmeyer stated earlier, complaints are generated from a variety of sources, and the board only takes actions on complaints the board receives. She also pointed out that the board on very rare occasions may open a new complaint. In conclusion, the data the board was able to provide does not indicate any disparate treatment based on the outcome of investigations and discipline versus complaints. Thank you.
Thank you very much for that very labor-intensive report. Appreciate it very much. I knew it took some time. Thank you. Are there any questions from board members? Dr. Kraus, please.
This is an issue that will never go away and always needs our constant attention. The statistical effort that was taken is admirable, but for those of us who submit scientific publications to journals of peer review, we know that before you can make sense of statistics, you have to do a probability analysis. And I'd like to see at our next meeting the p-values. Because, for example, we can look at odd numbers and we can say, well, there must be some prejudice if of the 4.4% complaints of a particular group, 4.9% ended up in discipline, or if the when the discipline rate is higher than the complaint rate, one has to self-question. But there is random distribution in mathematics and statistics. So all of these numbers need to be looked at with a statistical analysis to look at p-value to say, what is the probability of having this disparity just by random distribution? And if any of these numbers have statistical significance, then we should apply greater attention to them. But there is no doubt that in every place of the world, even in the United States, that there is bias, there is prejudice, there is racism, and it's not going to go away. And rather than to dismiss a charge, we have to take it upon ourselves to be constantly surveillant. And to do this analysis is an important part of that. So I don't think we should view this as just a way of appeasing people who complain, but it's important for us to be constantly introspective. Each of us sitting in this room individually think that we harbor no prejudice. But each of us sitting in this room think that most of the people in the room have some prejudice. And you always have to question it. Each of us may have been victims, perpetrators, or witnesses of prejudice. So I applaud the people who bring this to our attention and constantly remind us of it. And it's important for us to keep doing this analysis. Thank you.
Dr. Lewis, can I just point out, because I know where Dr. Kraus is coming from, I did want to state that the statistics, you can't state that it's of the 4.4% complaints that got the discipline, because that's each year that those actions were closed. So it could have been the 4.9 was based on complaints that were received earlier. So you can't compare those one to one. So it's based on the total discipline that was taken in that year, absent of when the complaint was received. Okay, so I just wanted to point that out for everybody in the everybody that's reviewing it.
Any other comments from members of the committee? No? Did you want to make a comment first?
I know that we have a couple of speakers who want to speak on this topic, and I just wanted to remind the speakers that because this is a subject related to discipline, I want to ask you to not discuss anything related to a case. This is because the board is prohibited by the code from having any information related to a case, any case-specific information, before it is formally before the board. So if you're providing any materials to the board, I'll need to look at those to make sure that there isn't any case-specific information. So I just wanted to generally state that.
Thank you very much for those comments. I have two comments from members of the audience. First one is Ms. Savang Chung from the CMA. Would you come forward, please? Thank you.
Good afternoon, Yvonne Chung, California Medical Association. We just wanted to express our appreciation to the board for putting this data together. As you know, CMA represents, in addition to representing all physicians, we have relationships with subsidiary groups, a lot of ethnic medical organizations, and I think they will find this information to be very helpful. I would encourage the board to continue to do this kind of analysis on complaints. I think it's not just an academic exercise. I think it's a good way to target certain groups for further education. If you start to, even not just by ethnicity, but by geographic area, by specialty, I think this is a really good way, someday when we get the information in Breeze and we can do this more easily, to really start to analyze where your complaints are coming from, where the discipline is happening, and use it as a tool for improvement and helping to address some of these issues before they arise. So I know it's very time intensive, and we really do appreciate staff's work on this. Thank you.
Thank you for your comments, Ms. Chung. The final speaker that I have here is Dr. Anthony Jackson and Dr. Arnold Savage. Would you please come to the speaker's table? Thank you very much. And we have, between the two of you, we have 3 minutes to make comments, so I appreciate you taking
Thank you,
on.
Mr. Chairman. And also, I want to thank Dr. Howard Cross for those very culturally sensitive remarks. And also, most of all, I want to thank Madam President, Ms. Kimberly Kirschmeyer, for putting this topic on the agenda to be discussed. It's a quintessential matter that we must address forthwith and honestly. And as you know, we appreciate the statistics. We've provided some data of our own, but I believe it was the late, great Benjamin Disraeli from Great Britain who said, correct me if I'm wrong, he said, there are lies and there are damn lies, and most of all, there are statistics. So Dr. Krause is most certainly on point when he says that we need to see P-points to back up these statistics, because our data tends to indicate that, in fact, Houston, we do have a problem. And with that, I'd like Dr. Arnold Savage, who is the co-minister of health for BAPAC, which is our civil rights organization, to read a letter from its chairman, Mr. Percy Pinckney, who is the president and founder of BAPAC.
Thank you. Indeed, I also concur with Dr. Krause's comments. And I'm going to read a letter from the president of the BAPAC, called Black American Political Action Association of California, Mr. Percy Pinckney. And the board members here have this letter before you. I'll read the rest for the audience. This letter is dated on the 23rd of this month, addressed to Mrs. Kimberly Kirschmeyer. It was also copied to Honorable Anna Cabrillo, Secretary of the Department of Consumer Affairs, Josh Gorbin, who is the Senior Advisor to the Governor, Alice Hoffman, who's the President of California NAACP, Dr. Anthony Jackson, who sits before here as the Health Minister for BAPAC, and Awad Kadane, I don't know if that name is correct, but Director of Department of Consumer Affairs, and Mr. William Jamal Miller, who's Director of Health Equity. It states that, Mrs. Kirschmeyer, the NAACP and BAPAC are, as you know, California's two largest civil rights organizations. Both groups have received countless complaints for years regarding the medical board's desperate treatment of ethnic minority physicians. Our Minister of Health, Dr. Anthony Jackson, has raised some global concerns in an agenda set for discussion today on today's board's enforcement committee. Empirical data and prima facie evidence has been provided, which indicates that the medical board's disciplinary demographics may provide a nexus for 10 various forms of discrimination. This proportionality disproportionately seems to adversely affect Black and Hispanic physicians. This also could cause patient harm. The board's mission is to protect the public from harm. So the BAPAC must ponder the issue. Is this an X factor which accounts for the racial divide between health and healthcare burdens in California. The Honorable Governor Jerry Brown recently created the Office of Health Equity to specifically study such health disparities. So it is my official capacity, as the president of and founder of BAPAC, respectfully must ask, would the Medical Board of California voluntarily agree to participate in a study regarding disparate demographics under the auspices of the Office of Health Equity? Now, since the Medical Board is also a subsidiary of the Department of Consumer Affairs, BAPAC will ask the Department of Consumer Affairs to also facilitate this study. Thank you for your cooperation. The other part of my statement states basically that in complete alignment with Dr. Cross, we have a lot of data, although this data didn't present with statistical proof about what goes on. And what I think we should do, we do know that things go on that are inappropriate in terms of racial discrimination among all groups. And we should really, this board should really find a means to address the issue of how to reduce the investigators' propensity to have I'm going to give credit, an unconscious bias of how they look at a given problem. And that's what I'd like to propose, along with the issue proposed already. Thank you.
Thank you very much, Dr. Savage. Dr. Jackson, do you have any summation of your comments for us?
Yes, I do.
You have time.
More specifically, I would like to ask the board to make a motion to see whether or not they will, pursuant to Mr. Percy Pinckney's request, voluntarily agree to participate in an objective study. All right, that will take a hard look at this data under the auspices of the Office of Health Equity, which the Honorable Jerry Brown created specifically for these type of situations. As Ronald Reagan said, we trust the board and their data and their statistics. However, trust but verify. And we believe that the Office of Health Equity, which was recently authorized under Section 1310195, would be perfect. They specifically have a statistical unit which knows how to analyze this type of data and come out with the whole truth and nothing but the truth. And we think this is what's needed. And until such occurs, there's going to be an ongoing suspicion that black physicians and or possibly Latinos are racially being profiled and being disciplined in a discriminatory and draconian manner. And I think this is something the board needs to address forthwith, once and for all. And we need to ask and answer the question, is this causing patient harm? Because if you look at the morbidity, mortality statistics, you can see that the disparity in health and health care between African Americans and other minorities is way off the Richter scale in comparison to their white counterparts. Dr. Cross.
Does that conclude your comments? Thank you very
does.
much. Thank you very much. Dr. Krause.
Before we would make a motion, I would personally, with the board's approval to be determined, request that Ms. Kirkmeyer investigate the suggestion and report back to us with more information before we commit to following that particular pathway. But I think that these are issues that we have to have under constant surveillance, and we can't ignore them.
Yes, I agree. We have ways to look at this information back at the medical board. We're just seeing your proposal and your recommendation for the first time. So I think, as Dr. Krause says, I think the staff needs to look at this as probably a potential agenda item, and it wouldn't be appropriate to make a motion today when we haven't had a chance to digest it and massage a little bit. So, but thank you for your recommendation. We will take it under advisement. That's
Right.
okay with
Fair
you, okay?
Fair enough, and thank you.
Okay, thank you for your comments. Okay. Well, we're coming to the next agenda item, and that is our adjournment. So do I have?
So moved.
Oh, we have a future agenda item. Sorry, I didn't see that. We have future agenda items. I'm out of turn. Are there any comments or suggestions for future agenda items? We We had one. So anybody from the board?
I would like an update from DOJ about our enforcement issues. I would like to hear some statistics. I would like to hear some compare and contrast, and I'd like to see some paper copies of what's going on.
Yes,
Both DFI and DOJ, everybody.
everybody.
I mean,
invited.
it's been now it'll be 6 months that you guys are in charge. I want to know how we're doing.
I think Mr. Gomez has a standing invitation, I think, right?
Yeah, he
Yes.
knows.
And same as Ms. Castro, they all have standing invitations, so we will
It's
see
no
you
different
again.
than we used to hold our staff to the feet to the fire. Their feet needs to be to
Yes.
the fire as well.
Any other future agenda items for the Enforcement Committee? Seeing none, do I have a motion for an adjournment?
You have so moved.
And remind of the committee that with the Executive Committee will start promptly at 1:30. We have to stay on schedule, and it's 1:20. So we have a motion to adjourn?
Yes, you do. You had it twice.
Yes, adjourn.
Members of the public?
From whom? Well, they should use a letter opener.
I'm going to call the Medical Board of California Executive Committee meeting. Good afternoon. I want to ask all of us to please turn our cell phones to silent and make sure they're off the table so we can avoid unnecessary feedback noise. You may notice committee members accessing their laptops during the meeting. They are using their laptops solely to access committee meeting materials that are in electronic format. This is an official business meeting of the Medical Board of California Executive Committee, and as such, disruptions of our business will not be tolerated. We have designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the committee's business. Should anyone disrupt the meeting, I will ask the person to conduct himself or herself in a manner that permits the committee to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before making your comments. Please ensure that if you are watching the committee's webcast, that you turn down your speakers when you address the phone via teleconference. To request to make a comment during public comment period, please press *1. You will hear a tone indicating you are in the queue for comment. If you change your mind and do not want to make comment, please press the # sign. Assistance is available throughout the teleconference meeting. To request a specialist, please press *0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the committee has limited the public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. This is so that the committee can ensure that it gets to all its business. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. C. Vang, hello, hi, will be assisting me with receiving the public comments via teleconference during this meeting. The committee welcomes public comment on any item on the agenda, and it is the committee's intent to ask for public comment prior to the committee taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and you will be recognized. I would also like to remind all speakers to complete a presenter slip so that I can call you by name at the appropriate time and that the record of this meeting is full and complete. Please give the speaker slips to Ms. Toof. Lisa Toof, can you identify yourself? Hello, good afternoon. I will do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make a last-minute comment. But we ask you to fill out a speaker slip after your comments so we have it for the record. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. Thank you. I would like to call this meeting to order and ask Ms. Toof to please call the roll.
Dr. Bishop?
Here.
Dr. Gonadev?
Here.
Dr. Levine?
Here.
Dr. Lewis?
Present.
Ms. Pines? Ms. Yaroslavsky?
Present.
Mr. Serrano-Sewell?
Present.
Thank you. We have a quorum.
Thank you. Quorum is present. Moving to agenda item 2, public comments on items not on the agenda. I have no speaker slips. Mr. Vang, are there any comments on the phone?
There are no comments on the phone lines.
Okay, thank you. If not, let's continue to our next agenda item 3, approval of minutes from the May 1, 2014 Executive Committee meeting.
I move to approve.
A motion by Dr. Lewis to approve, second by Ms. Yaroslavsky.
Yes.
Any discussion, members? Seeing none, all those, are there any comments from the public? Seeing no comments from the public. Any on the phone?
There are no comments.
All those in favor?
Aye.
Aye.
Opposed? Motion carries. Next item, we will move to item agenda 4, which is a discussion on the compendium of policies for the board. Ms. Kirkmeyer? Oh, yeah. Before our executive director, Ms. Simone, speaks, I just wanted to make a couple of comments. And that is, at our last meeting, it was recommended that the board put together a compendium of policies that could be used by staff as they review initial legislation and also to assist as legislation is amended during the legislative process. In some instances, these amendments may be made prior to a board meeting, and staff will have to testify on a bill prior to the meeting, to one of our meetings. In discussing this issue with Ms. Kirkmeyer and Ms. Simones, it has been determined that in addition to this compendium bills that have a significant impact on the board business, I will be speaking with Ms. Kirkmeyer to determine if there needs to be an interim executive committee meeting so that we can take position on a bill prior to a legislative hearing. Of course, if we do that, a 10-day notice would be provided and a teleconference executive committee would be held. However, on some bills, it is thought that a compendium of policies would give staff assistance in providing feedback on bills that come up prior to board meetings. Staff has put this compendium together based upon input from members and meetings with the board and also discussions internally. Everyone has read the document, so Ms. Simones, could you take us through the 3 specific policies that are listed in this document? Our discussion today will be to provide any input into this document, and if the language is agreed upon at this meeting, the items can be taken to the full board later on today. Otherwise, we can further discuss any amendments that need to happen and continue it to the next executive committee meeting. And lastly, I view these compendium of policies as a work in progress. So the colleagues don't feel the need to take action right now. I think these policy statements are important and will provide the guidance to legislators, to ourselves, and express to the public that we take these matters very seriously and wish to go on record. So why don't we discuss what we have before us? Thank you.
Thank you. Okay, as the chair said, we have 3 policy areas that staff is recommending for that the board possibly adopt. One is more complex, and that has to do with scope of practice, and then 2 are more straightforward. So I'll just go in the order that they're listed unless the members would like me to do something differently. So the first one is related to scope of practice. So as the board, many members know that The board has taken positions on the past that bills that impact scope of practice for healthcare practitioners. These bills can be difficult to weigh the scope expansion versus the need to ensure consumer protection. However, in the past, the board has both supported and opposed bills that would expand the scope of practice. And a recent example that probably all the members here remember is the Senator Hernandez authored 3 bills that all proposed a scope expansion. So SB 493 was a bill that would have proposed a scope expansion. I won't go over the whole thing. You guys probably remember it, for pharmacists. And in that one, the board believed that it was a scope expansion that would still ensure consumer protection, and we actually ended up supporting SB 493, and that passed and was signed into law. However, there was 2 other bills, SB 491 and 492, which were significant expansions of scope for nurse practitioners and for optometrists, and the board did oppose those because they did feel that they would they had the potential to harm consumers. And so those are some examples of where the board has both supported and opposed scope expansion. So if you go to page 4-2 is where the policy and principles start. So it would depend on the particular language in each bill, but board staff believes that the following policy statement could be adopted by the board due to the broadness of the policy for bills that propose scope of practice expansions. Number 1 is DCA, the board and other healthcare boards of the DCA are duty-bound, first and foremost, to protect and serve California consumers. Number 2, protecting and serving healthcare consumers requires that DCA and its member healthcare boards assure, as best as practicable, that healthcare consumers are evaluated and managed by California licensees practicing within their scope of practice as defined by law or regulation. B, evaluated and managed by licensees who are in compliance with all applicable federal, state, and local laws and regulations. C, evaluated and managed by competent licensees practicing within community standards of care. And D, entitled to be evaluated and managed in accordance with the highest standard of care applicable to any of the licensed or certified practitioners. 3, the board holds that all California consumers should know the background, training, education, certification, and history of disciplinary actions of any healthcare provider they may consider seeing. And 4, the board recommends that any legislatively proposed expansion of scope of practice include criteria to be met regarding education, training, certification, and continued oversight of any practitioner who obtains expanded scope. First and foremost, consumers must be protected, and any proposed scope expansion must assure adequate mechanisms and oversight to reduce patient risk of harm. Care provided to patients in California should be of the same quality regardless of who is providing the care. So I don't know if we want to take a moment to discuss that or if I should go through all 3.
Why don't we stop with scope of practice? And given the complexity of the issue, if the committee is okay, we can have a committee discussion first that may inform a motion. So are there comments from, I'll look to my left, right. Dr. Levine?
Just one comment, and I want to commend you on the write-up of this whole section. I think it was extremely well done and very thorough. In the paragraph, the last paragraph, I would, this is kind of an editing amendment, but I think it's also content. Between training and certification, I would put proctoring in there.
Dr. Levine, can you give us where you're at again exactly?
End of the section, number 4. The board recommends that any legislatively proposed expansion of scope include criteria to be met, including education, training, certification, and continuing oversight. And my suggestion is to add proctoring between training and certification. In particular, when there's a proposal to expand scope involving procedures or surgical procedures in particular, observation prior to certification is really important.
Thank you. Any additional comments to my left? You don't, I can come back, but I was just starting here. To my right, Dr. Bishop, Barbara?
I think it's absolutely excellent. My only concern, and I don't know that it should be a concern, is that under policy and procedures that the Department of Consumer Affairs is listed out, is called out. I mean, it's okay for us to make rules and regs for them?
It's more of a working with them during this process.
Okay, as long as that's okay. I mean, I think it's absolutely wonderful.
I also want to recognize Dr. Krause's contributions to this process. He was extremely helpful in guiding the internal discussions that we had in the production and presentation of this document. It could not have done without him, so we thank you. I see no further comments. Is there a motion? And then I'll take comment.
I'll move to present this to the full board.
There's been a motion and a second. Before we vote, are there comments from the public? Yes. Hey, just please state your name. That's okay.
Clarify the motion real quick.
Yeah.
I just need to make sure that we clarify the motion real quick. Is the motion as to just this one or to the entire?
Just this one.
To scope of practice, and also, thank you, to include Dr. Levine's
With the addition.
suggestion with the
Absolutely,
proctoring.
sorry, absolutely.
Thank you. That is the motion.
This actually is, we have no issue with any of the policy statements themselves. CMA actually does a policy compendium as well as does the American Medical Association. It's a pretty common practice for a lot of the medical associations. The only thing I would suggest is as you're thinking about doing a compendium, putting them on some kind of regular, we have a sunset review that we do on a particular calendar. It's a good way to sort of check. You might want to do an annual review, as most of these things are likely to apply for a while, but sometimes things happen where, you might want to be more specific or laws have changed. So as you put this forward to the board, you might want to suggest having some kind of mechanism to do that as well, so that it's always on your radar. That's it. Thank you.
Would you state your name? Or maybe you did. Did I miss
Yvonne
it?
Chung, California Medical Association.
Thank you. That is a great suggestion. Are there additional comment from members present? Public members? Any comments from the phone?
There are no comments. Thank you.
There's been a motion and a second. All those in favor? Dr. Krause, were you going to say something?
No, I was going to say something. Do we need to add to be reviewed every 6 months or annually to the motion or not?
I don't think that's necessary.
No? Okay.
LS2.
Yeah. Okay, there's been a motion and a second. All those in favor?
Aye.
Opposed? Abstentions? Motion carries. Wonderful. Next
Okay.
policy.
Moving on to continuing medical education. For some background, there are many bills that initially proposed requiring mandatory CME. Due to the board's history in opposing these bills, the chief of legislation, me, always advises the legislative offices that board would likely oppose mandatory CME. And many times you'll see those bills change to be something different, like encourages or something that's not a mandate. But our policy statement recommendation is the board opposes the concept of mandated CME topics. The board believes that each licensed physician should decide which type of continuing education is most appropriate for their particular practice. So if I had this behind me, then I could say the board has a policy on this issue.
I move to support the policy statement recommendation as stated.
Is there a second? Second. There's a second. Board discussion? Seeing no... Yes, Doctor.
It's a great idea because it's the only CME we mandate is where all the troubles are. That's the pain management. So it doesn't really do any benefit to the consumers, just adds additional burden and gets these pharmaceutical companies which sell drug to get involved in trying to get that CME.
Are there additional comments from the committee members? If not,
So we just all need to remember the reason why we do this is because there's always the disease of the month. And in all due fairness to the medical practitioners, the idea of having a very valid reason for having to take additional CME is really there. But the idea is, how do you decide which one is more important than the next one? And it's been a dilemma that we're not going to be able to fix. So therefore, we're not going to start it.
Okay, thank you. Is there any public comment from those in the audience? Just please state your name.
I will make a slip. Excuse me, Karen Ehrlich, licensed midwife.
Bless you.
Oh, dear. I would, as well as the pain management that Dr. Gnanadev just mentioned, based on what we heard this morning from the African-American representatives, it would seem to me that something about cultural competency, which would span all specialties, could be required. It's already required.
already in there.
It's already in
Thank
there.
you.
Yeah, we have to.
Thank you for raising that. Are there additional comment from those in the audience? Seeing none, any comment from the phone?
There are no comments in queue.
Thank you. There's been a motion and a second. All those in favor?
Aye.
Aye.
Opposed? Motion carries. No abstentions, I assume. Next, policy discussion.
Okay, moving on to funding for physician education. For some background, the board has routinely supported bills that provide additional funding for the practice of medicine. This includes bills that improve or provide more funding for loan programs, provide more funding for medical schools, and provide funding for additional residency positions. When these types of bills are introduced, I do advise the author's offices that board will likely be in support, but our policy statement recommendation is the board supports additional funding for physician education, including funding for additional residency positions, funding for medical schools in California, and funding for loan programs, including the Stephen M. Thompson Loan Repayment Program. That would be the policy recommendation that we're suggesting.
Second.
There's been a motion and a second. Discussion from the committee.
Are we in a position to ever suggest, I mean, aren't the residency programs, a number of those, isn't that a federal decision?
Some bills will provide additional funding, so we don't have to wait for that. Yeah.
It's complicated.
Yeah.
So, I mean, I'm not so sure why we're bothering with this, that's all. I'm not sure.
There have been bills in the past that that would fund additional residency positions not using federal funding, and we've supported those. So it doesn't happen, they don't pass very often.
I thought it was
but-
interesting of all the policy statements to come up with that this was a policy statement that you felt was important. That was all.
So the
Dr. Levine, and then I'll go to
federal
Dr. Bishop.
funding of residency slots comes from the Medicare
Right.
pot. And that number was frozen in 1997, I believe, Balanced Budget Act. Subsequent to that, many new residency positions have been created from different sources of funding. I think this is an appropriate policy statement for the medical board. There are, I think many of the bills that are introduced to increase funding come from the position of don't tax me, don't tax thee, tax the man behind the tree.
Yeah.
You know, the drug companies, the insurance companies, what's his name, Mark Zuckerberg. Somebody should put more funding in, and the truth is most of those have a difficult time moving forward because of whoever it is that's being volunteered to provide additional funding. But from a medical board perspective, I think this policy makes complete sense.
Thank you. Dr. Bishop?
I have a slightly related concern, and this is based on, although I strongly support funding for additional medical education, I'm just mindful of the recent cures legislation where the doctors bore the burden, which I felt was inequitable in funding that. And I'm very concerned by putting something like this out there because I suspect the we that we're going to tax will be the doctors if we're not careful. And I think, although physicians certainly bear a burden and are active participants in this, I'm always concerned with just giving a carte blanche to anybody.
Doctor?
I actually understand Dr. Bishop's concern, but tell you, I mean, all of you know already, California is in pretty bad shape when it comes to access to care. If you look at Inland Empire, alone needs about 3,000 more doctors. And just to give you some numbers, New York State with a population half as much as California has 13 MD schools. California, twice the population, has 9 MD schools. We got some real deep troubles. We need to find funding other places, not just the physician side, both for residencies and medical schools. And residencies, even though it was frozen, there is a loophole in that frozen area. That is, if a hospital never had residency before, you can start and you will have 5 years to get capped out. So there are places we can, with the help of state and other sources of funding, we can give them the preliminary funding, and then the CMS will take over and fund them. So there are ways to do it. I think we should do whatever it takes to get it done.
Thank you. Are there any comments from the audience? Seeing none, are there any comments on the phone?
There are no phone comments.
Thank you. There's been a motion and a second. All those in favor?
Aye.
Opposed? Nay. Okay, one opposition. Any abstentions? Motion carries. We'll now move to agenda item 5, discussion and consideration of committees, task forces, and subcommittees. Both I and Ms. Kirkmeyer will give this report. In the board's strategic plan, every other October, the board should review the listings of committees to determine the necessity of the committees, its roles, and whether the committee needs to continue or can be retired. In August, I met with Ms. Kirkmeyer to discuss the board's committees. I want to thank Ms. Kirkmeyer for coming out to San Francisco so we could have that about 3.5-hour discussion, so thank you. The recommendations from this meeting are listed on pages Exec 5.1 to Exec 5-5, on pages Exec 5-6 to Exec 5-16. There is a document that identifies the current committees with their roles, membership, and charge, their issues. The main goal of reviewing the board's committees is to find efficiencies, assist with time commitments for the members, and increase output from the committees. As you can see, it is recommended that the board keep enforcement, licensing, education and wellness, and the executive committees as standing committees and continue with them for the next 2 years. For the executive committee members, it is recommended that it be made of the board officers, the president, vice president, and secretary, the immediate past president, Dr. Levine, and the chairs of the enforcement, licensing, and education and wellness committees. That would put us at 7, I think.
Yes.
Yeah. There are several of our committees that are required by law, and of course, it is the recommendation to keep those committees. The Special Faculty Permit Review Committee, Midwifery Advisory Council, the Application Review Committee, and the Special Programs Committee. However, it is recommended that the Application Review and Special Programs Committees be combined. The duties and function of those committees are very similar, and there is no requirement to keep them separate, just that we have a committee to discuss applications and special program applications when necessary. It's also those committees don't meet as often, so we can combine those two duties. Thank you. As you can see in the documents in this section, the recommendation is to eliminate the Access to Care, Cultural, and Linguistic Competency Committee and its subcommittee. The committee hasn't met in several years, and there has been no need to have this committee. The role of this committee, which was to find ways to improve access to care and also to hear an update on cultural and linguistic competency in continuing medical education, can be put into the Licensing Committee and the Education and Wellness Committee. The Committee on Physician Supervisory Responsibilities is another committee that has completed its main purpose. However, this committee has brought up a few other issues. These issues, though, it is our belief, could be placed in either the Enforcement or the Licensing Committee as appropriate. If additional discussion is needed on an issue, it is better done at an interested parties meeting rather from within this committee. This issue can be brought back to the appropriate standing committee, licensing or enforcement, for the appropriate action before going to the full board. Lastly, it is recommended that the board eliminate the subcommittees and task forces with the exception of the prescribing task force, which has continued responsibilities pertaining to prescribing practices. These two member committees allow staff to work with the committee and to hold interested party meetings. The information is then brought to the full board for action. Therefore, it is recommended that it continue. And I want to, before we have a discussion, just wanted to reemphasize a couple of points that Kimberly and I discussed. One is we want to increase the output from the committees. We realize that our times are valuable. We're busy with other engagements. And my thinking was to expand the scope of authority with each of the committees that would, if approved, would go on for the next 2 years. Wasn't to limit anything or discussion, rather to give those committees and their chairs the authority to go about their business, have the necessary meetings, hearings, interested party meetings, and then come back to the full board with a report and possible action. So you see the work before you. Before we could take a motion, Kimberly, would you like to make some comments?
I just wanted to make one comment that on page exec 5-2, when I wrote this memo, I inadvertently left off in the recommendation, the membership of the executive committee would be the president, vice president, secretary, immediate past president, and the chairs of the board standing committees. It was just a drafting error, and I apologize for that.
Absolutely. So that committee is now currently comprised of 6, and it would go to 7.
We go to 7, right.
Because I'm adding, well, it is recommended, my thinking is to add the chair of there would be 3 standing committees now. Enforcement, licensing, which we have now, and the 3rd standing committee, which the chair would have a seat on. The executive committee would be the Education and Wellness Committee, which is currently chaired. I've asked Barbara to continue in that capacity.
Yes.
Are there any, is there anything else, Kimberly, to add?
That was it. You
Thank you.
covered everything.
Before we take a motion, are there questions or comments from staff? I mean, from my colleagues? Doctor?
It's a great idea. Just to quote one of my favorite business side gurus, Peter Drucker, one of the ones he mentions is every organization has to look into on and off to really do something called organized abandonment. That is, you have to eliminate certain things. You can't be doing everything forever. And so we are just combining function into something. That's all what we do.
Absolutely. Should the need ever arise on a special subject matter issue, I would confer with all of you, and we could assemble a task force. But I think this will serve the board well. Is there a motion?
So moved.
Second.
Second. Any comments from the public? Those present? Any comment from the phone?
There are no comments from the phone.
Seeing none, there's been a motion and a second. All those in favor?
Aye.
Opposed? Abstentions? Motion carries. Thank you. Update on the strategic plan? Kimberly? Item 6.
I would like to ask each of you to turn to EXEC, Exec 6-1 to 6-21. And on these pages, you will find an update on the board's new strategic plan. As you can see, we have color-coded the document as well as have provided a section where the status of the objective is listed, including any action that has been taken. With the new strategic plan, several items identify something that has to happen each quarter or monthly. In the past, we may have had certain dates that things needed to be done, but in this one, we've really identified those items that have to be done on a quarterly and monthly basis in some avenues. So for those, board staff will identify that it has been completed by placing green in the date column at the update, each meeting that an update is given for the past quarter, basically, or the last month that that's been done. If we weren't able to get something done, we will put red in the column. If we are working on something, it will be yellow. The majority of items in red in the pages that are in front of you are really due to the board's inability to run enforcement reports in our BREEZE system. You'll see those ones are red in there. Our ISB staff continues to work by themselves on some reports and with DCA on others to try and get the reports finalized, as you heard me go over earlier today. Others are red because of lack of resources. Several key positions have been vacant, specifically with the absence of a deputy director and a chair of enforcement, which will assist with some of the special projects. Right now, I'm basically having the staff that would assist in these, helping me in those roles that would have been done by those individuals. We will work on these items in the next quarter to ensure we are meeting our goals. I want to make sure that the members like the presentation since this is the first time we've presented our new plan, so any feedback is really appreciated. And I'm not going to go over each one unless members have specific questions on any of the specific items.
Any questions or comments from the committee? Ms. Yaroslavsky? And then I'll go to my left.
Dr. Levine, I would defer to you.
Oh, Dr. Levine?
So just on exec 615, this is more an observation.
Okay.
Exec which one?
6-15. So it's the,
On smaller pages next time, too.
no, it's fine.
No,
Actually,
it's perfect.
I appreciate being
Okay,
able
all
to
right.
read it.
Just maybe put the page numbers on the left instead of the right.
That's a good idea.
Smaller pages would be a problem. On 41C, I would suggest adding the Senate and Assembly Health Committees. Many of the issues that come before us in legislation actually either originate in or come to the health committees. And so I think it's important for the members of those committees to understand the board and its functioning.
Check. You don't go to Senate Health right now when they come as new members?
To the new members and occasionally, but usually they just call me when bills come.
Okay. So we'll put that down when we go through and do our rounds.
It's a suggestion. And under 42B, in reading through the individual elements in the far right, it seems to me there may be a more efficient way to reach larger stakeholder audiences. Going hospital by hospital is a pretty inefficient use of our poor public information officer and, to some extent, the board's time, because I think it would be helpful for board members to be involved in these presentations. And all of the associations, all of the stakeholder communities have associations that meet. California Primary Care Association, the California Hospital Association, CMA, CAPG, where informational, breakout sessions or informational plenaries could actually carry the message of the board to much larger audiences than, no problem responding to requests, but in terms of thinking going forward, in terms of a strategy, I'd love to see the associations included, and also trying to match board members, putting the face of the board members in these presentations. Thank you.
Those are great suggestions.
Yeah.
We will capture that. Thank you.
So are you looking to do this as a whole thing, or are we going to go from the beginning through it?
Well,
Does not go.
this is just an update, I believe.
Yeah, just
There's no.
I just wanted to ask about a missing part that I was worried was missing, and maybe it was my mistake, and I
Please,
remember.
please.
And that was in the licensing and the review of approved schools, foreign schools, and the re-review of them on a regular basis, as well as the review of new schools that were looking to be reviewed.
Which number, which goal are you looking at? I'm
So
sorry.
at 1.1, define
Okay.
what is necessary to, oh, no, then, wait, not the, wait. So it's not there. It's not there. It's not on the goals. I apologize.
Okay. But that is something that we work to, Kurt does an update, Mr. Warden, does an update at everyone on the status of where we are on the schools. It may not be, and I don't
What
think
I'd
it is
done is
actually
read
in our
not by
strategic
the,
plan.
I'd not read the goals. I'd read by who was doing what.
Okay.
So my apologies.
But that is something, just Ms. Yaroslavsky, just so you know, that is something we have to get back to, is going out to the schools again.
Or at least developing a schedule to do
Right,
that.
right.
More so than going out.
Are there additional comments or questions from the committee members? Seeing none, is there any public comment from those in the audience? Any comment from the telephone?
No questions in queue.
Ms. Kirk, oh, nothing? Okay. Thank you for that update. We will now move to Agenda Item 7, future agenda items for the Executive Committee. Do any members have any future agenda items for our next meeting?
How are we on your budget issues.
Good question.
Had budget issues at all for a while. Ms. Kirkmeyer, are you okay with budget?
Yes, that's actually in my executive report, if you want to ask questions this
I didn't know if you
afternoon.
needed something for, I mean, if within the executive committee, there was like a vehicle by which quarterly we did certain things and quarterly we did
Okay.
other things instead of doing, that might be also of benefit. And this is
Okay.
like coming to the end of the, or starting prior to the next
fiscal year.
year, that might be an issue. But I'm not suggesting that it's necessary,
All right.
just that maybe that we have some.
Your point is well taken. Are there additional suggestions? Is there any public comment from those in the audience on future agenda items? None? Are there any comments from those on the phone on future agenda items?
No comments.
Okay, thank you. We will now move to agenda item 8, the annual evaluation of the executive director, and the committee will be going into closed session. Cell phones to silent and to make sure they're off the table so we can avoid unnecessary feedback. You may notice board members accessing their laptops during the meeting. They are using the laptops solely to access board meeting materials that are in electronic format. This is an official business meeting of the Medical Board of California. As such, disruptions of the board's business will not be tolerated. We have designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the board to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before making your comments. Please ensure that if you are watching the board's webcast, that you turn down your speakers when you address the phone via the teleconference. This is to avoid feedback. To request to make a comment during the public comment period, press *1 and you will hear a tone indicating that you are in the queue for comment. If you change your mind and do not want to make a comment, please press the # sign. Assistance is available throughout the teleconferencing meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the board has limited public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Si Vang, hello, will be assisting me with receiving public comments via teleconference during the meeting. And members of the public, this is done so the board can get to all its business, but in no way will he limit the public's right to speak. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak to that agenda item, please raise your hand and you will be recognized. I would like to remind all speakers to complete a presenter's slip so I can call you by name at the appropriate time and that the record of this meeting can be full and complete. Please give the speaker slip to Ms. Toof. Ms. Lisa Toof, hello.
Hello.
Good afternoon. Thank you for identifying yourself. I will do my best to call upon everyone who has supplied a slip for an agenda item and recognize those who wish to make a last-minute comment. But we ask that you fill out a speaker slip after your comments so that we have a complete record of the board's business. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to end today at 6 p.m. We may take some items out of order to accommodate the schedule. I would like to introduce some friends in the audience. Kathleen Nichols, Eric Ryan, hello. Troy Holmes, Jose Partida, and Renee Threadgrill. They are from the Health Quality Investigative Unit. Thank you for joining us today. I would like to call the meeting to order. Ms. Toof, would you please call the roll?
Dr. Ganadev?
Here.
Ms. Pines? Dr. Bishop?
Here.
Dr. Kraus?
Present.
Dr. Levine?
Here.
Dr. Lewis?
Present.
Mr. Louie?
Here.
Ms. Shipsky? Here. Ms. Wright?
Here.
Ms. Yaroslavsky?
Present.
Dr. Yip? And Mr. Serrano Sewell.
Present.
Thank you.
We have a quorum. Good. Now thank you all for being here. Moving to agenda item 2, public comments on items not on the agenda. Genevieve? Ms. Clairval, hello.
Genevieve is just fine.
Okay, good to see you.
Good afternoon. I want to bring the issue of course, about Ebola, and I just wonder, if the medical board going to take some statement on a guideline for hospital in California to deal with, and also about the television anchor, Dr. Nancy Schneiderman, who decided to break the quarantine and go out to get some food. I think maybe a letter of reprimand will be appropriate. Thank you.
Thank you for your comments. Mr. French? Hi, Jack. Hey.
Hello, my name is Jack French. I'm here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that is organizing patient safety advocates from across California as the California Patient Network. I want to speak with you today about our recommendations related to how the medical board communicates to consumers and the public regarding disciplinary action it takes against physicians. In the interest of patient safety and transparency, the medical board should make information regarding physician discipline as readily accessible to the public as possible. In recent years, this board has varied in how it reports physician discipline in its quarterly newsletter. At times, the medical board included a brief description of offenses for which the physician had been disciplined, as well as a link to the documents associated with the physician's discipline. At other times, the board included a description of the offense, but no link to the documents. The board's most recent newsletter, Summer 2014, includes a link to the public documents associated with the physician's discipline, but no description of the physician's offense. We recommend that the board return to its previous policy of including its newsletter a paragraph description of the disciplined physician's offense, in addition to the link to the disciplinary documents. This would improve transparency and the ability of the public and patients to understand the nature of the offenses the medical board takes action on. Also, the board routinely emails a list of actions it takes against disciplined physicians. The board includes a link in this email. Unfortunately, the link takes one to a medical board page which describes Breeze. It requires a maximum of 6 clicks actually to find the physician's disciplinary record. Unfortunately, many people probably do not reach the disciplinary record in just 6 clicks because, as we have testified before, the Breeze website is extremely confusing to consumers who are trying to find their way to a physician's disciplinary documents. We recommend that in its emails regarding physician discipline, the medical board provide links directly to the public documents associated with the discipline. As the board already does currently in its newsletter, we also recommend that these emails consistently include a short description of the disciplined physician's offenses. Thank you.
Thank you for your comments. Are there additional comments from members of the public? Are there any comments from the telephone?
No comments on the phone line.
Thank you. With that, we'll move to agenda item number 3, approval of minutes from the July 24 and 25, 2014 meeting. Are there any additions or corrections to the minutes from the members?
No.
Seeing none,
I move to approve.
Second.
there's been a motion to approve and a second. Are there any comments from the public, from the audience? Seeing none, any comments from the phone?
No comments on the phone line.
There's been a motion and a second. All those in favor?
Aye.
Opposed? Abstentions? The motion carries. Thank you. We will now move to agenda item 4, which is an update and consideration of recommendations from the Midwifery Advisory Council meeting. Hello.
Hello. My name is Carrie Sparrowhon. I'm the chair of the Midwifery Advisory Council. Thank you for hearing my report today so that I can get back on a plane to St. Louis. I don't want to rehash any of the information that all of you have from my report in the packet, but I do want to just hit the highlights of what's been going on with the Midwifery Advisory Council over the last 6 months. The hospital transfer form is now being used by hospitals, and discussion continues in the form of interested parties meetings to determine if more information should be included on that form. Licensed midwives continue to be challenged in the realm of obtaining drugs and testing deemed necessary for safe practice, and we're all still working on that. The task force on licensed midwife assistants submitted language to the MAC that is based on language for medical assistants and naturopathic physician's assistants. The MAC voted to send this language to the full board for a legislative proposal for the new legislative session in 2015. Jennifer Simoes, Chief of Legislation, will present that language tomorrow to you. I urge you to please really consider it. It's something that we all really need. The information packet for new board members is still in progress, as is CNM to LM licensure. The interested parties meeting regarding the creation of a list of medical conditions that would require an LM to refer a client to a physician for evaluation was held earlier this month. There was good input from all parties, but no consensus was reached. It is expected that both ACOG and CAM will work on this issue prior to the next interested parties meeting for this regulation. Further discussion on the content of the hospital reporting form, which was supposed to happen at that same interested parties meeting, was held for another time because the discussion surrounding the list took a really long time. Does anybody have any questions on any of that? Clarification?
Any questions or comments from the board?
Okay.
Seeing none?
Then all I need from you is an approval of the following agenda items for our December 4th MAC meeting. Task force updates, the midwife assistant task force, the board information packet task force, the licensed midwife annual report data collection tool task force, an update on regulatory changes required by Assembly Bill AB 1308, an update on interested parties meetings, the one that was just held in October, and an update on the certified nurse midwife to licensed midwife.
Is there a motion from the?
So moved.
So Ms. Yaroslavsky made the motion. Is there a second?
You have one from Mr.
Oh, I did. Thank you, Dr. Judge. Appreciate it. Any comments from the public?
What was the date of the meeting again?
It's the 4th, I believe.
Thank you.
4th of December.
Okay. Are there any comments from the phone?
No comments on the phone line.
I appreciate that. All those in favor of the motion?
Aye.
Aye.
Opposed? Abstentions? Motion carries. Thank you.
Thank you all very much.
Safe travels. We will now move to agenda item 5, board member communications with interested parties. Do any members have anything to report? Doctor?
Just a reminder that because it's a public meeting.
Yes.
I do get involved with a lot of issues at AMA level. I'm on the AMPAC board, and I do deal with the CMA. So I just want to let you know, but medical board issues are not discussed.
Thank you. I'll look to my left. Any other comments? To my right? Yes, Mr. Kraus, Dr. Kraus?
Every time I offer it, I'm told I don't need to state it, but I feel obligated to do so. That I sit on the board of directors of the California Ambulatory Surgery Association. We oversee outpatient surgical centers. I'm a trustee for the California Medical Association, but there have been no parties that have brought matters to me that are before the board at this meeting.
Thank you. Is there any public comment from those in the audience? Seeing none, are there any comments from those on the phone?
No comments on the phone line.
Thank you. We'll now move to agenda item 6, President's Report. Dr. Ganadev and I continue to meet with the board's executive staff twice a month to discuss projects at the board and to ensure everything is moving forward as needed. I do want to report also and thank the doctor, the vice president, for being on those calls. I know we find them very helpful and effective in going about the board's business and establishing the agenda for these meetings. Panel A elected a new chair, Jamie Wright, so she'll be serving in that capacity. Congratulations in that. But also want to acknowledge and thank Barbara Yaroslavsky's work as chair of that panel. She's done a phenomenal job, and we've all benefited from her leadership. So thank you very much. Was there an election in panel B? What is the Dr. Ganadev? Wonderful.
I'm the chair, and Dr. Cross is the vice chair.
Great. Thank you for your continued service in the panel work. Here I'd also want to give an update. The executive committee met in closed session to evaluate our executive director. We did that. There were no, so we fulfilled that duty and we'll provide that report to the Department of Consumer Affairs. But want to take this opportunity to say thank you to our executive director for doing an outstanding job in all respects. You enjoy the full confidence of this board. Are there any questions or comments from the members? Okay. Is there any public comment from those in the audience? Are there any comments from anyone on the phone? No?
No comments on the phone line.
Oh, absolutely. In addition to panel A electing Jamie as chair, we also elected our good friend Dr. Lewis as vice chair. Thank you for doing that. Appreciate it. And your work as chair of the enforcement committee. Thank you.
You're welcome.
Seeing no comment from those on the phone, we'll now move to agenda item 7, update and consideration of recommendations from the executive committee meeting. I'll start this, if that's okay, Kimberly. The executive committee discussed, we had a few items. There's a couple that I need to bring to the full board's attention and seek your approval. The first being the compendium of board policies. This issue was raised at our last board meeting, you may recall. Dr. Kraus had recommended that, and we all agreed, that the board put together a compendium of policies that could be used by staff as they review initial legislation and also to assist as legislation is amended during the legislative process. Staff put together a draft of a board compendium based upon input from the members and our past experience, I think, past practice. At the meeting today, the executive committee members discussed and approved the 3 policies as outlined on pages exec 4-1 to 4-5. These 3 policies are pertaining to 1, scope of practice, continuing medical education, 2, and 3, funding for physician education. These policies will provide guidance to staff on any legislation and to the public that is received regarding these 3 topics. The committee approved the policies as written, with the exception to add the word proctoring to the policy on scope of practice. I would like to request a motion to approve the executive committee's recommendation to approve these 3 policies as written and amended for scope of practice and discussed at the executive committee meeting.
So moved.
There's a motion. Is there a second?
Second.
Are there any comments or questions from members of the board? Doctor?
This has been discussed previously, but I think it's worth restating that it's the board's intention that these compendia be added to and modified over time.
Yes.
So a policy exists from one board meeting to the next, but can always be modified. And the principal purpose is so that our legislative advocate has positions which can be represented to the legislature between board meetings.
Absolutely. We know it'll be a useful tool in that respect, and it is a living and breathing document that can be revisited at the will of the board. If there are no further questions or comments from the board, are there any from the audience? I have no slips. No? Are there any comments from the telephone?
No comments on the phone line.
There's been a motion and a second to approve the policies, and we can, all those in favor?
Aye.
Aye. Opposed? Abstention? Motion carries. Thank you.
I just like to abstain.
Okay, 1 abstention, motion carries. The next item I'd like to bring to your attention, members, is, excuse me, committee structure. Also at the executive committee meeting, the members discussed the current committees of the board. In the board strategic plan, every other October, the board should review the listing of committees to determine the necessity of the committee, its roles, and whether the committee needs to continue or can be retired. In August of this year, I had the opportunity and met with, for a few hours, our executive director to discuss the board's committees. Again, I want to thank Kimberly for coming out to San Francisco so we could have that productive meeting. The recommendations from the meeting are listed on pages exec 5-1 to exec 5-5. The main goal in reviewing the board's committees is to find efficiencies, assist with time commitments for members, and to increase output from the committees. At the executive committee meeting, the members approved for recommendation to this full board, keeping the enforcement, licensing, education and wellness, and executive committees as standing committees and to continue them for the next 2 years. In addition, to make the executive committee comprised of board officers, the president, vice president, and secretary, the immediate past president, Dr. Levine, and the chairs of enforcement, licensing, and education and wellness, those 3 standing committees. That would bring the executive committee to 7 members, if you were keeping track. The executive committee members also approved for recommendation to the full board, keeping the special faculty permit review committee, the midwifery advisory council, and the application review committee, and the special programs committee as they are required by law. The board approved consolidation of the application review and special programs committees, as the duties and function of these committees are very similar and that there is no prohibition to keeping them separate. So we're going to combine those 2 and they'll be able to effectuate their subject matter area and it'll be more efficient. Finally, the executive committee members approved the elimination of the Access to Care, Cultural and Linguistic Competency Committee and the committees on physician supervisory responsibilities. It was suggested that issues pertaining to these committees be placed on either the enforcement or the licensing committees as appropriate. If additional discussion is needed, it is better done through an interested parties meeting rather than within this committee. The issue can then be brought back to the appropriate standing committee, licensing or enforcement, for appropriate action before coming to the full board. The committee members also approved the elimination of the subcommittees and task forces, with the exception of the prescribing task force. Members, in consultation with Ms. Kirkmeyer, we made these recommendations, as I stated earlier, to improve the efficiency and your time commitment. I know each and every one of you is very busy, and what this has done, essentially, is expanded the scope of the standing committees by providing them greater jurisdiction within each of those standing committees, so the work product is full and substantial. And also to retire the committees that have not met for quite some time or served their initial purpose, why they were created in the first place. Are there questions or comments from the members?
We have no questions from
Okay. Are there any additional questions or comments from the board members? No, seeing none. Is there any questions or comments from members of the audience? Well, we can also probably take a motion first. Is there a motion to approve? Thank you, Barbara. There's been a motion and a second. I'll ask for public comment one more time. Okay, seeing none. All those in favor?
Aye.
Opposed? Abstentions? Motion carries. Thank you. Off to a productive year. Item 7, update and consideration of recommendations from the executive committee meeting. Wait, we just did that, sorry. I apologize. Item 8, executive management report. Ms. Kirkmeyer.
Good afternoon. I would like to begin by asking for a motion to approve the orders following completion of probation and orders for license surrender during probation.
So moved.
Second.
All those in favor?
Aye.
Opposed? Abstentions? Motion carries.
I will not be going over all of the administrative summary, the enforcement program summary, or the licensing program summary unless someone has a question. I did want to point out two things from the summaries, though. One is the significant increase in the number of complaints in fiscal year 13-14, which we are attributing to the new Breeze system. The board received over 1,000 more complaints this year than in the last year. The other thing that I wanted to point out is that over the summer, we hired a student assistant who interviewed licensing staff, attended a licensing fair with Mr. Shunke, and then scripted and produced a video tutorial to assist applicants with the licensing process. This video tutorial is posted on the board's website, but more importantly, it's posted on each page of the online application, and it has a link to instructions on how to complete that specific page of the application. And actually, we know that one school actually had it running during a recent licensing fair, so individuals could actually go there and stand and watch it. This is only for the application that is printable and downloaded. The instructions aren't for the actual online Breeze application, but we're hoping that it's helpful to the applicants. I wanted to let the members know that Ms. Simoes and I are working on a Senate and Assembly Business and Professions Committee staff, with those staff, for a board legislative day. The members, in teams of 2 with a staff member, would meet with members of these 2 committees to provide information regarding the board, its consumer protection role, and its functions, as well as answer any questions from the members regarding the board. Although a date is unknown at this time, it has been suggested that this take place in February. More information will be provided to members as soon as we are able to establish a specific date. Although the board is actively participating in outreach events, a lot of them are regarding fraud or senior scam events. We thought it would be a great idea to put together a health care outreach event. We've suggested the idea to other allied health boards, and there is a lot of interest. The idea is to have presentations from each board as to what they oversee, and then the overall importance of ensuring the public checks to see if their healthcare professional is licensed and where to submit a complaint. It would also be a thought that after the initial event, they would be more than happy and more focused specific topics, so more outreach on specific topics. And then the board associated with that topic would attend the event. Board staff will be working on this idea, and more information will be forthcoming. As most of you probably noticed, the board posted in the meeting materials that it is now assisting with CARES registration, and that's occurring at this meeting. We will also be allowing individuals to come to our office in Sacramento and to the probation offices in San Dimas and Cerritos to register. In addition, and this is probably one of the biggest things, is that Mr. Shunke will also be allowing for 2 to 3 hours when possible during his outreach event to assist individuals in registering for CARES. So we did notice we have a few bugs to work out today, but we will be making sure that that's all available for physicians as we go forward with that. And then lastly, I wanted to provide an update on the coordination with other state agencies regarding the issue of prescribing psychotropic medications to foster children. Based upon an investigative report regarding psychotropic medications, on August 25th, Senator Lieu sent a letter to the board asking for it to look into the inappropriate prescribing of psychotropic drugs. Mainly, he wanted the board to determine if psychotropic drugs not approved for children were being prescribed to them, and also to determine if these drugs were being prescribed without review of the child's medical records or drug history. Senator Lieu also asked the board to identify recommendations to minimize these dangerous practices. Upon receipt of the letter, the board began to look into the issue. We first contacted the Department of Social Services to request a meeting on the issue, and then after the meeting was held, we also attended, it was also actually attended with staff of the Department of Healthcare Services. Since the initial outreach, the board has become very involved in this issue. It's actually kind of taken on a life of its own, quite frankly. Ms. Somoza and I have attended a meeting held in San Francisco by the California Child Welfare Council where this issue was discussed, and we also determined that the best way to identify physicians who may be inappropriately prescribing was by establishing a memorandum of understanding between the board, the Department of Healthcare Services, and the Department of Social Services. So we've met with Healthcare Services to begin the discussion, have a meeting scheduled actually in 2 weeks with both Healthcare Services and Department of Social Services to discuss this memorandum of understanding. In addition, Paulette Romero and I are attending meetings on a quality improvement project basically that is putting together guidelines for the use of psychotropic medication with children and youth in foster care. We're also attending, Ms. Romero is also attending a data and tech work group on this issue. Once the guidelines I mentioned are complete, we can post them on our website, and we'll also do a newsletter article. The board will also continue working with both agencies to obtain the information necessary in order to identify physicians who may be inappropriately prescribing. Throughout this process, we have encouraged all stakeholders to report any physicians believed to be inappropriately prescribing to the board. This concludes my report. Are there any questions?
Yes, going back to the CURES database and trying to do outreach for those groups, I don't know if we've asked this before, whether there's money in a budget, but there are groups like the CMA and my Union American Physicians and Dentists that meet on a regular basis, either twice a year or once a year. I'm wondering if those types of meetings would be conducive to having a registration booth where you could assist these people.
Do a registration.
And actually, right now, what we're doing is we're kind of acting as that notary, because right now, the doctor has to go out. It's still a very cumbersome process for the physician. I think that's something we need to look at once we have an easier registration process. But if you would like somebody from our board maybe to go out during those events and be there to take the information, but the doctor has to walk in with a lot of the information, so we'd have to get the information out to them ahead of time. So I don't know if CMA would be willing to do that work with us.
Hi, Yvonne Chung, California Medical Association. In answer to your question, the Department of Justice, at least they've done this for our events. I believe they've told us if we can get 20 or more physicians at an event, they will send somebody out from there. I don't know if this is still the case given their current resources, but at least for the last couple years, we've done this at our Legislative Day activity. And I know that some medical groups and others have done this as well. So it may not be the board that needs to. You can also reach out to DOJ and they will do it as well.
Oh, good, thank you.
Thank you. Are there additional questions? Doctor? Yes, Gennady?
Kim, I publicly want to appreciate what you did with the foster children issue. To be honest with you, with the public, that it's physicians are dragged in this issue, but real issue is these kids need help, and it's not coming. They need family therapy, they need psychotherapy, they need resources. That should be social services department, and that's where the concentration should be rather than what drugs are prescribed. That's just an easy way out. I hope those agencies and the state will take on and seriously try to help these kids, because if you can prevent something and help educate these kids, I think we'll get a lot more out of them rather than drugging them or putting them in jail.
Thank you. Are there additional questions or comments? I'll look to my left. Nothing? Thank you. Any additional questions or comments on this end? All right, thank you. Are there any questions or comments from members of the public? Oh, Dr. Levine?
Yeah, again, I want to affirm what Dr. Gennady said. The speed of response to this inquiry from the senator and the speed with which action was taken was really remarkable, and I think it's a great testament to the degree of preparedness of the entire staff of the medical board under Kim's leadership to, rather than defending or saying it's not our problem, is actually saying we can be part of the solution whether or not it's our problem, and taking immediate action. It was remarkable and noticed by a lot of people.
That's the new standard.
I just want to actually also thank Mr. Serrano-Sewell, because he was really influential in meeting with staff and getting what we needed to send and giving us direction as well. So we also had assistance.
Thank you. Team approach, absolutely. And a lot of input from everyone. I do have a public comment. Genevieve Clairval, did you? On 8? Executive Director's report.
Good afternoon, Geneviève Claverol. You know, I have been voicing my opinion about cures for quite some time, and this is a very inefficient and not very well functioning software. And I am concerned how safe it is and how people can access that information. And I'm not the only one asking that. I mean, I've spoke to people who are involved in many states, and they said the one we cure in particular is extremely vulnerable to that. And it's still taking a lot of time to have the information updated. And, you know, someone asked about the money. Technically, the money won't be accessible until June 2015. So I am concerned of the energy which has been spent over the last couple of years for a very defective software. When, you know, Claoma, which is one of the systems I have loved from the beginning, they have up to almost to the minute information in their system. With 1 hour time, they know who has purchased. And that's what we need. I mean, if you really want to stop. But what we have to do now, take days, and they cannot communicate software-wise with 23 other states. And if you want more information, is a wonderful website which is called the National Alliance for Model State Drug Law. We'll give you a breakdown of all. I'd be glad to share that in link with you.
Thank you for your comments. Are there any additional comments from members of the audience? Are there comments from the phone? Agenda item 8.
So you're attracted to scope.
None?
No, there are no comments from the phone. No.
9, okay, Eric. Thank you. We'll now move on to agenda item 9, Federation of State Medical Boards summary. Ms. Kirkmeyer?
In your packets under tab 9 is an update of the Federation of State Medical Boards. I'm not going to go over the report unless anyone has questions. I do want to let the members know that the Federation staff and our liaison are planning to attend the July 2015 board meeting and provide an update on the Federation and its activities. The Federation usually visits state boards about every 4 to 5 years, so we're about due for their visit. On the Interstate Compact, the final language of the compact is listed under agenda item 9C. Board staff will be providing an analysis at the January meeting on the complete compact. One thing to point out is that because this is an interstate compact, the language of the compact as listed in 9C must be adopted by the California legislature precisely as written in order for the compact to be valid. This is something we will be taking into consideration as we perform our analysis. The Federation has also sent a notice that they are seeking resolutions by February 24th of 2015 for their annual meeting. If any member has any resolution they would like to put forward, please contact me to discuss your idea so it can be developed and presented at the January 29th and 30th board meeting for approval. Then the Federation is also seeking nominations for elected officials. I sent out information to all members regarding these positions, and Dr. Levine has decided, after much coaxing, no, not really, to run for a board of directors position. So I would actually like to ask for a motion to approve the preparation of a letter of recommendation and support for Dr. Levine.
So moved. Second.
Motion in a second. Is there any comments from the public other than let's get the letter out, or from the board? Questions from the board? Comments? None? Okay. Any comments from the audience?
Cookies.
Any comments from the phone?
There are no comments from the phone.
All right. Dr. Levine, 2014.
Yes, we will need all the help in putting those buttons together. And then the Federation is also seeking individuals who are interested in serving on committees within the Federation. 4 members have actually stated their interest in being appointed to a committee following the April 2015 annual meeting. Dr. Levine is interested in being appointed to the Ethics and Professionalism Committee. Dr. Lewis is interested in being appointed to the Education Committee. And Ms. Wright is interested in being appointed to the Editorial Committee. And Dr. Krause is interested in being appointed to the Bylaws Committee, as well as any other committee where his service may be of assistance. So I'd like to ask for a motion for those recommendations. We do a letter of support for appointment to those individuals to those committees.
So moved.
It's been a motion. Second. Is the second?
Yes, and you have a second over here for Mr.
Thank you. Is there any questions? Questions or comment from members of the board? Okay, seeing none. Comments from the audience, members of the public? Any comments from the phone?
Nope, we have no comments from the phone.
Thank you. All those in favor?
Aye.
Aye.
Okay. Motion carries. Thank you. We have a public comment on the update on the Interstate Compact. See, you're not? Yeah, I know. I was like flashback
Charge of interstate commerce?
from Law School 101.
Charge of interstate commerce?
Constitutional law.
We have comments on a lot of things.
Yes. Hello.
Yvonne Chung, California Medical Association. I just wanted to bring the board's attention to the Interstate Compact. CMA will be doing an analysis on this as well, and we encourage board members to take a very close look at this document. It is, as Ms. Kirkmeyer indicated, it has to be passed in its entirety, and that's an issue that has come up with our membership as well. And so there are certain inconsistencies with California standards versus what is in the compact, and it's still sort of unclear how those differences would be resolved. We have issues regarding confidentiality and sharing of information, potentially sharing patient records between states as well. So we're not opposed to the concept, but we believe there are many, many issues in this compact that have yet to be determined or have been left somewhat undefined, including, how would you pay for it? How much would it cost? And our understanding is that currently they have enough states signed on to enact it. I think they need 7. I think they said they have 8 right now. So there is some time to take a step back and not rush into it. Thank you.
Thank you. I have a comment card from Marion Hollingsworth. Hello. Good afternoon.
Good afternoon. My name is Marion Hollingsworth, as you said. I am here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that is organizing patient safety advocates from across California as the California Safe Patient Network. I want to speak to you today regarding the Federation of State Medical Boards Interstate Compact. Our initial review of the Interstate Medical Licensure Compact raises the concerns for us in 4 different areas. Number 1, the lack of any requirement that the Interstate Commission include consumer patient representatives. 2, the lack of assurance of reasonable access to public meetings of the Commission. 3, the lack of assurance of public access to information in the database of the Interstate Commission will maintain. And 4, the lack of assurance of transparency of the investigative and disciplinary procedures of the Interstate Commission. We'll be in touch with the board in the future to share future concerns and more detail. Thank you so much.
Thank you for those comments. I have a speaker's card from Julie Felmuth. How are you?
Good afternoon. Julie D'Angelo Felmuth from the Center for Public Interest Law at the University of San Diego School of Law. First of all, welcome to San Diego.
Yeah.
At least I think I'm in San Diego. I'm going to shock you. The Center for Public Interest Law agrees with the California Medical Association and Consumers Union Safe Patient Project. We have some concerns about this compact, and I'm happy to lay them out in more detail and get them to your staff and your attorneys before their analysis at the January meeting. But I just want to say that I've watched this process in other professions. Some of you may know that we look at 25 different regulatory boards, and this has been attempted in many other professions. The way this has apparently been presented to you and the way that it will apparently be presented to the California legislature as a fait accompli with which, no change can be made, procedural, substantive, or punctuation change, is not feasible. It is not possible, and it's not realistic. And when the legislature has been presented with proposals like that in the past, the legislature's knee-jerk reaction is to just say no. And so I just wanted you to be aware of that I would actually prefer it if the Federation put this compact out for a formal public comment period where everybody could comment on it, and then they put out their quote-unquote final version with which all boards must agree and all legislatures must agree. Because there may be some unintended consequences that even they are unaware of. Again, we have similar concerns to those of the Consumers Union, and I will put them in writing and get them to your staff before your January meeting. But I just wanted to let you know that thank you.
Thank you for those comments and all those comments on the issue of the compact and other points in the executive director's report. To my left. Oh, yes. Dr. Levine.
Just as a point of information for the board, that one of the reasons I agreed to make myself a candidate for the Federation Board was attending the annual meeting last year and watching the process that occurred around the Interstate Compact. And California is a large and important state in this country, and the ability to influence this once the board approved it was essentially nil to make changes, to make recommendations, in spite of Kim's and my efforts both to say that that we, the state of California was not going to back down on established consumer protections, and we got nowhere. I'm probably speaking out of school, but let's just say our suggestions were not accepted. And I do think on something like this, there was a legitimate and valid reason to approach the issue of an interstate compact, because as the Federation presented it to us, the alternative was legislation in Washington for national, when we've talked about this before, the board for national licensure, that is, a physician licensed in any state could practice in any state, and great concerns about what that meant for consumer protection. This was, and there were large commercial interests behind making that happen. So in the face of that, an expedited process for multi-state licensure that still kept the responsible licensing and enforcement functions in the home state and did not gut the ability of a state medical board to carry out its licensing and enforcement functions seemed to make sense. But as all of the speakers have pointed out, it's very hard to even consider accepting something with that doesn't represent the same level of consumer protection that California has established.
Yeah, when this came up, I had the same concerns. I mean, it's just amazing even to look at us being the state of California, not state of Nebraska or Wyoming or one of those places. Our input wasn't there, and when you hear that you have to take it the way it is, that really bugs me to death. It doesn't make sense that somebody telling us it could be our own organization, which we're all together, but it doesn't make sense. So that's why I think it's important to have. I'm glad that all three entities here are doing the same, analyzing it very carefully, and so will be the medical board. So we got to very carefully look at it before we go to our legislature to support or not to support, and I doubt that it will succeed significantly without California support. That I'm pretty well sure. We are the largest state in the nation.
Thank you. Dr. Lewis?
Yes, when I looked at the membership of the various committees of the Federation, I was so surprised that I don't know if there's either one or two representatives from the state of California. It's very, very minimal. We have one of the largest states, population of physicians, and we're so underrepresented. I was just screaming. So a reason why I wanted to be involved in that federation, at least get our foot in the door so we can represent California.
And I did just want to make one point. We have, as Dr. Levine has said, we've sent in, numerous feedback on the issue. The one issue that we had really been pushing in is the fingerprints, and they did add in fingerprints to it, and actually it is for California. However, they just didn't go as far as we would do, in that we would want it in our own state, so we would have that subsequent arrest, and that really is one area that is a big issue for us. So.
Ms. Yaroslavsky?
I would suggest that the discussion about national licensure through the FSMB has been going on for a while. It's been going on for a while because they need to, I think, to validate why they're in business. The issue, when it first came up and I was at the meeting, the discussion was if you would meet at least the minimum level of what California licensure expects, then maybe we would consider the discussion. So that didn't go anywhere. So I would just urge this board and all of the groups out there to take a careful look at what this means. And my only concern is that once it does pass in the federation level, if California has to participate. I mean, in my understanding is we don't have to participate, but will we be forced into, so the better that, it's better at the beginning to try and be part of the party, you know, it's better to play ball at the beginning than to wait till the game is over and then you want to play ball. So I look forward to hearing the discussion. I'm sure it will be an active and an important one. I want Dr. Lewis to know I was on the bylaws committee. I found it to be extremely stimulating and important. I was on the education committee, and I'll explain to you why I was no longer on the education committee when this meeting is not public. But the sensitivity to the needs of California and to the broad, diverse community that California represents was not as well received as it should have been. Let's leave it at that.
Interesting. Seeing no further comments from the public, and thank you for members, your comments. We'll now move to agenda item 10, update and consideration of recommendations from the Enforcement Committee meeting. Our chair, Dr. Lewis.
Okay, I'm on. Okay, we had a very long and productive meeting, almost 2 hours, so I'll try to be as brief as I can and give you the summary of our Enforcement Committee meeting. The committee was joined by Ms. Kirchmeier and Deputy Attorney General Jane Zach Simon, who provided information regarding the pain management expert reviewer policy. And by way of background, in 2002, the board established a policy on the review of cases involving pain management issues. At that time, the policy stated that for certain cases, the board would require at least 2 expert reviewers. One physician had to be certified in pain management specialty. The other was certified in the specialty of that physician being reviewed. Since the requirement for physicians to obtain a CME has been in effect since January 2002, the board and the Attorney General Office do not believe the policy should still be required, and that's the CME requiring so many CME hours in pain management. The committee held a discussion regarding this matter and is seeking a motion to change the pain management expert reviewer policy to require 1 expert reviewer in the like specialty rather than 2 expert reviewers. Then we moved on to a discussion regarding the proposed amendments to the board's statement on marijuana. The statement adopted by the board on May 7th.
Do we need Dr. Lewis, we may need a motion on that.
On the first part?
Yes, please.
Okay, thank you. We need a motion.
So moved.
So moved.
So moved. All those.
You got a second?
Second.
You have a motion and a second.
And then we have comment?
Public comment.
Public comment? Comment on the phone?
No comments.
And then Dr. Bishop has a comment.
Sure. As one of the co-chairs with Barbara of the task force on prescribing, I'm a bit concerned about that. I think it's come up on multiple occasions during our meetings that there are expectations that do differ based on the physician's specialty and their skills, such that I know one of the real experts we've relied on who's a pain specialist at one point said, now wait a minute, this is what I do, but this is not what you would expect another physician to do who's not a pain specialist. So I think we should be cautious that if we do go to a single reviewer, that reviewer is cognizant that there are expectations that differ between the ER doctor, the internal medicine doctor, and the dedicated pain specialist with respect to the way they care for patients, because I think that could put some physicians in a bind that would be unfortunate. Barbara, you may want to comment, see if I'm off track on that.
Fine. What you have to say?
Dr. Krause?
I would think and hope that all of our reviewers are conscientious enough to know that if something may transcend that which they view as within their specialty, that there would be a criticism for a colleague having practiced without consultation. So I don't think that every physician who practices pain management within the scope of his or her practice needs to have an expert pain management reviewer.
So I think that where Dr. Bishop was going is that we want to make sure that the person that's doing the expert review is the same person that's in the same specialty as the doctor that's being investigated. Correct, Dr. Bishop? That's what you said, correct? I just make sure that that's what was heard.
Well, but what I read in our paper here is that every physician should know all about pain management, which isn't.
Well, what we have now is we have a situation where all doctors take a certain amount of CME and mandatory.
Right.
The issue is that if you are in pain management, we're going to have one reviewer for for expert reviewer. And the issue is that the expert reviewer has to be in the same profession, same specialty as the doctor that's under review. When it's a pain management doctor, practice, sorry, thank you. I need a translator.
Dr. Bishop, it was changed actually during the committee discussion from what's in the packet. So I'm sorry, our motion probably wasn't very clear of what the motion was. So really, the motion was that we would no longer have two experts. It would be one expert. It would be one expert, but it would be in that area of practice rather than pain management. So that was what the committee
Thank you.
was supposed to be.
I remember I had to leave because I was creating a quorum, so I wasn't exactly kicked out.
That's the best part.
The key word.
Come back.
The key word is the like specialty
Right,
or
thank you,
area
I'm
of
sorry.
expertise
Right.
of that physician being reviewed. So that should clarify that. Okay, and we need a vote.
So
All
you,
those,
all those in favor
all
of the
those
motion?
in favor?
Aye.
All those opposed? Any abstentions? Motion carries. Moving on to the next item. Ms. Kirschmeyer also provided information regarding the proposed amendments to the board statement on marijuana. And this statement, adopted by the board on the May 7, 2004, clarifies that the recommendation for marijuana by physicians in their medical practice will not have any effect against their physician's license if they follow good medical practice. The board staff have reviewed the statement and believe edits need to be made to the statement as some information is misleading and does not comport with the current law. The first series of edits pertain to the term medical marijuana. We don't say medical marijuana anymore. Although marijuana can be recommended for medical purposes, the term medical marijuana is misleading as there's no difference between regular marijuana and marijuana used for medical purposes. Another issue with the statement is the assertion that the initial examination for the condition for which the marijuana is being recommended must be in person. This statement contradicts board's telehealth law. The initial examination must follow the standard of care and must provide for an appropriate prior examination. However, the law does not require that this examination be in person or face-to-face person, but it could be through the telehealth system. The committee held a discussion regarding this matter and is seeking a motion to direct staff to update the statement on marijuana as amended with the statement modifications and post a new version to the board's website. So
I'll move that motion.
okay, we have a second
Yes, you do, right here, Dr.
right there.
Krause.
Okay. Do we have discussion in the audience? Do we have discussion, comments on the telephone?
I have no comments on the phone.
Do we have any further comments from board members?
So do
Bernadette.
we get that statement next meeting, or when do we get that statement?
I can send it to you. Once I make the edits that were approved at that
Edits.
committee meeting, I can go over those if you want to hear what they are, Dr. Gonadev, or I can just send it out to you, all the members.
So what I'm asking is that, are we approving the changes to those now, or is it coming
Yes,
after? Okay.
you were approving it
Now.
now. Yeah, sorry.
What we're approving is just the updating and taking and making the statement legal according to law today.
Current law, it's not,
So it's just tweaking. It's not spelling changes. It's not even spelling changes. It's just tweaking. So that we are in line with current California law.
and we're striking the term medical marijuana and using marijuana for medical purposes.
Dr. Lewis,
medical use.
just one moment. If you agree, Dr. Lewis, we could ask council to go over some of those changes so everybody is fully informed.
Okay.
Is that okay? Wonderful.
Go ahead.
If you're looking at your enforcement packet, in number ENF 5-1 to 5-3, all the edits that were previously in there that have been underlined, stricken out, those will remain the same. On page ENF 5-2, number 3, it will say provision of appropriate consent rather than informed consent. That was an additional amendment that was made. On number 6, it will say proper record keeping and maintenance thereof. That supports the decision in the middle of that page. The paragraph directly under number 6, it will say, in other words, if physicians use the same care in recommending marijuana to patients as they would recommending or approving medications, they have medications, they have nothing to fear from the medical board, because we didn't want it to say any other because it's not a medication. And then on ENF 5-3, the top paragraph there, the last line where it's struck out for medical marijuana, it will say marijuana is as good or better than other treatment options that could be used for that individual patient. So in addition to the ones that are currently listed, those are the additional ones.
Is that clear?
Yeah, I'm just, when it came to telehealth, I'm just trying to see if, are we even going to make the problem even worse with someone sitting at a desk somewhere there and prescribing marijuana by looking at the video monitor? So that's what my concern
Needs to be covered in a
was.
separate motion.
Well, if I may, Dr. Lewis, this updated policy, well, not this updated policy statement goes over what was just discussed and ensures compliance with the existing state law as it pertains to treatment and prescribing. So that's what we're doing.
Recommending.
Related issues will be taken up later by the board.
Separate.
Yeah, separate. Thank you.
I was explaining that telehealth is consistent with the law, so do we, okay, when motion's been made, been seconded, all those approve?
Aye.
Aye. Opposed?
I'm not opposed, but I just want to make just a comment is that we need to let the physicians know because a lot of them get into disciplinary issues by not following guidelines. So I'm not even sure what they're going to take this telemedicine marijuana prescription, how they're going to take it. So we need to educate what is the right way of doing it, what's the wrong way of doing it, rather than go through nonstop through the disciplinary process.
So, Dr. Ganadev, I just want to let you know that your concerns are similar to my concerns, and they have been the same concerns that we've had since time immemorial that this has been on the books. That the rules do not change as far as what a doctor has to do currently in order to make a medical recommendation for marijuana. They have to continue to follow those. The only change in that is they're taking the word informed consent and changing it to appropriate consent. So if you look at
Well, just a moment. If it's okay, Dr. Lewis, I think the board voted and it was approved.
Oh, okay.
Okay.
Sorry.
So just as a matter of continuing
We're in
our
the middle of our
I apologize.
report. So we have the, we said it, all those approve?
Yes,
Approve?
it was approved.
All those opposed? Abstentions? The motion carries.
Thank you.
Okay. May I move on?
Yes, please.
Okay. Next, the committee received a presentation from the representatives of the University of California, San Diego Physician Assessment Clinical Education Program, PACE, who talked about the redesign of the PACE program from its current 3 days down to a 1-day program. So we heard a brief presentation from them. Then
7 days to 3 to
what?
7 days.
7 days down to 3 to
5.
5. Sorry, 7 days to 3 to 5. They've shortened it and they've combined many things into a very short period of time, so hopefully be more efficient. Then Ms. Carrasco from the Board Central Complaint Unit gave a presentation on the utilization review. Ms. Carrasco reported the findings following the board's evaluation of the utilization review complaints for approximately the last 18 months. It was found that 58% of the utilization review complaints received alleged the review resulted in a decision that impacted the patient's care. The Central Complaint Unit processed these complaints as quality of care issues and attempted to secure any additional information relevant to the case, and had a review performed by the medical consultant. In all cases, the consultant found no evidence that the opinions reached by the reviewer were inappropriate or outside the standard of care. At this time, staff suggested the board continue to perform preliminary analysis of the complaints involving the utilization review, with emphasis on those related to quality of care. Okay, I'm going to move on to the next issue. Next, Mr. Gomez from the Department of Consumer Affairs Health Quality Investigation Unit provided an update of the transition of staff to Department of Consumer Affairs. And Mr. Gomez also explained the difficulties faced by the Quality Investigation Unit in retrieving data for statistical purposes due to the BREEZE database. Next and final comments are involving Ms. Kirchmeier and Ms. Robinson, then presented the committee with information regarding the cultural background of those individuals who have had complaints filed against them, who have been investigated, and those who have had disciplinary action taken against them. Staff will consider a review of this type of data via a vigorous statistical process in the future. And that concludes my remarks of the Enforcement Committee meeting today.
Mr. Chair?
Yes.
There's an important item that relates to the marijuana issue that I believe it would be better to address at this time rather than to have it sit overnight. And do I have permission to make a motion?
Well, do you mind if I confer with the executive director?
You might want to hear what the motion is.
But I would prefer that it be addressed in this session.
I understand.
Rather than tomorrow.
What about none of that?
So, Doctor, if I may, Dr. Lewis?
Prerogative, go ahead.
Thank you.
I yield to my distinguished colleague.
Or yields.
Doctor, it's if there's no disagreement with the chair of the Enforcement Committee, I don't have an issue with it per se, but let me add, I don't want you to percolate overnight. However, we are going to have a robust discussion around legislative proposals. And this, what I think you might be saying, might be more appropriate for that agenda item, where we will have a discussion and provide direction to staff around legislative proposals for the next session.
Mr. Chair, I do agree, but I am concerned in light of this being a public meeting and these issues being under discussion today, that letting this particular issue lie overnight without some indication of the board's direction could open us for overnight criticism.
I have no objection to it if the chair doesn't, nor council, but you know what our preference is. I should say it was my preference.
I think what you can probably do is you can probably go ahead and do it now, but then also restate it at the agenda item that calls for legislative recommendations, proposals.
I would be happy to introduce a motion which could be tabled for tomorrow.
Okay.
And that motion would be to move board support for legislative action to require that a physician's marijuana recommendation require an in-person evaluation by a California licensed physician.
Oh, I'll second that.
I would third that.
Against the current law.
Can I have a?
But I would move to table. You want me to move to table?
Okay. You'll second the motion to table it. Okay, thank you.
No, but if you're not going to discuss it now, then you would entertain a motion to table.
Yes.
So I'm going to table the motion.
Okay.
Okay.
There's no objection to tabling the motion?
Should it be tabled to time definite?
Yeah.
Well, when we discuss legislative proposals, which is agenda item 21B.
No objection.
Thank you.
Okay, as part of my report, which this comes under, we will table it to the appropriate place on the legislative agenda item tomorrow for further discussion. Okay? We've heard it, and we will definitely introduce it.
Without objection, we'll move to Agenda Item 11, Vertical Enforcement Program. Mr. Gomez and Ms. Castro.
Yeah.
Good afternoon, Mr. President and members of the Medical Board of California. Michael Gomez, Deputy Director for the Division of Investigation and Enforcement Programs for the Department of Consumer Affairs. Regarding the VE program.
Slow it down.
Oh, sorry, am I doing that again?
Slow it down.
We have time. Thank you, Mr. Gomez.
You know, I was looking at I was actually back here talking to Renee. I was supposed to have a 5:45 flight, but I figured I'm not going to catch it anyway.
We'll try to get you on that.
I don't think it'll work. At the last board meeting, exactly. At the last board meeting, I had indicated that the division was following the July 1st, 2011 version of the Vertical Enforcement Manual that was agreed upon by the Medical Board of California and the Attorney General's Office. I also reported at that time that the Department of Consumer Affairs and the Attorney General's Office was planning to meet on a revision of the current manual to look at better definitions and protocols related to how we could create some efficiencies in the current processes that we are using. In my assessment, and as I'm learning the vertical enforcement program at the HQIU side, and to date, we have formed a work group which consists of the director of the department, Awet Kadani, my chief deputy, Tracy Ryan, myself, Gloria Castro, and her staff, our legal counsel, and a retired deputy chief from the Medical Board of California, Laura Sweet. I'm happy to tell you that we have met 3 times. We have, and just talk about process a little bit. We have a very structured agenda. We have agreed upon components that we are addressing at each of these meetings, and it's been kind of a robust discussion and discovery for me, certainly in understanding the nuances of the existing vertical enforcement programs that we now share in our partnership. We have had the meetings are, just talking process again, the meetings are pretty structured, and at this point we have a partial completed draft of the beginnings, if you will, of the current vertical enforcement manual that relates to protection of the public, the mission, if you will, the principal vertical enforcement and prosecution definitions under Government Code 12529.5 and .6, and the roles of the VE team member, which previously we hadn't included the medical consultants in that definition, and now we have included them as part of the VE team, if you will. And we are now at the point where we are now discussing resolving disagreements in terms of the investigation, where we may have issues related to evidence and the process that we are using in the current vertical enforcement program. Our hope is to have a completed draft for a final document by the second week in December of this year. And just to let everybody know that in this effort that we have taken, and I appreciate, Gloria, your openness and our discussion of this. And it's I got to see the prosecutor side of her, by the way, just to let you know. She's
a prosecutor.
Yeah, exactly. But we're trying to glean as many efficiencies as possible from this, and we have put everything on the table for review and discussion for potential refinement of our internal processes. Our next meeting is scheduled for next Wednesday and the 29th in Sacramento, and I'm optimistic about our approach, and we have been, as I said before, Gloria has been very open-minded about this process, and it is process-driven. But I think in the initial discussions we have discovered, I've discovered at least, the work of the Attorney General's office a little bit better, and hopefully it's been reciprocal in terms of my trying to better define the roles of our respective roles in this vertical enforcement partnership. I will tell you that My commitment is to make this work. We all want to make this work on the behalf of the consumers, and it is the law. It is one of those projects that we must, and I believe we can accomplish. We just need to pursue the process that we're using and have a healthy debate as to how we can make it better. If you have any questions, I'm willing to answer those questions. How was that, Mrs. Yaroslavsky? Did I do that better?
It's fine. It's the second time around. I understood it just as well this time.
Why don't, how about, thank you. Ms. Castro?
Thank you so much. I just want to remind the medical board, it's only been 4 months since the transfer on July 1st, 2014.
It's a long time.
Yes, well,
112 days.
yeah, and only 286 cases have been opened under Mr. Gomez's leadership, and all other cases were developed under the leadership of the medical board investigators led by the executive director. The carryover cases that were developed by the medical board number about 700 cases. So I believe that, in my opinion, the stable of cases that have to be worked out, that were truly the medical boards and were started under their oversight, have to be washed out in order for us to truly be able to assess whether or not HQIU is doing things differently, better, et cetera. So in the spirit of fairness, I just wanted to remind everyone of that, to be patient, so that we can truly get a reflection of whether or not HQIU's impact is measurable, okay? For the past year, since the transfer has been mandated, much of the board's focus has been on the mechanics concerning the movement of personnel, hardware, software, technicians, telephones, all that stuff, the stuff that was covered in the MOU. And I would submit that those tasks are easy, comparatively speaking, when we actually talk about what the heart of vertical enforcement is. And that's the cases, that's public safety. And we are engaging very actively and constructively in the transfer of knowledge, the transfer of techniques, and also getting to learn the history of our new management over those investigations. But I think we both agree, obviously, that the protection of the public is at the heart of this, and that is achieved through high quality and efficient joint investigations. And that's the whole point of why we're here today. And so, like Mr. Gomez reported previously in the Enforcement Committee and just now, the rest of the hard work has begun in earnest, and that's the continuation of the 8.5-year-old vertical enforcement and prosecution program, which was instituted in 2006, and the continued direction of those investigations by the Attorney General's office. And the product of our labors remains constant and focused, notwithstanding the change in the leadership of the investigators, because essentially, although the factory is under new management, the board of directors is still present and demanding accountability. And so Ms. Kirchmeier is actively engaged in every aspect of our important work. She sits at the table with us. And I think it's very important that she has agreed to be there, not only to supervise, but to know what's going on and to hear what she has to say. Gomez and I serve the board and serve Ms. Kirchmeier. At this point, I want to reiterate that I have a great deal of admiration and respect for all of you board members and for Ms. Kirchmeier, her depth of knowledge and history with the medical board and DCA. Let's not forget, she did leave for a little bit and went to DCA and came back as our executive director. And so she's been a constant influence on our work, and we are all very lucky to have her involved. And yeah, so. In addition to my constant communications with Ms. Kirchmeier, our office is endeavoring to minimize the time that we bill for administrative tasks relating to the transition. I keep it very, very focused. I want my supervising deputy attorney generals and lead prosecutors to be involved in those kind of policy discussions led by me. So that way our DAGs can continue to stay focused on their legal work of protecting the public along with the investigators. Of course, some of the changes have resulted in additional billings, so I just want to warn you about that. And we continue to have to bill, obviously, in many respects, to have to explain the elementary concepts to our new partners. And so I ask for your indulgence and being patient with us as we undertake that transition process. Because as we move forward and we get acquainted with each other, those aspects of those billings will be reduced. And so as HQIU has become aware of the business process and the workflow with its investigators, the HQIU has continued many of the technical aspects that were perfected by the medical board over many years in handling its own investigations, and of course in other areas. But I am open-minded and listening to the new ideas for efficiencies that are being proposed by DCA executive staff. And so, in the meantime, our AG staff is following the July 2014 manual, which already had a lot of efficiencies that I thought needed to happen, and I've shared those with Mr. Gomez, and that's what we're going to start discussing at our next meeting, I think. Of course, as expected, like I said, we're interfacing on a daily basis in investigations, and what we don't want is a return, obviously, to the handoff model, which was abolished by the vertical enforcement statute. And we will continue, obviously, to reinforce that your matters are very, very important. They're different than any other matter that Mr. Gomez has been aware of, and I think he finally understands what Kim and I were trying to tell him, that these are very special matters involving public safety. And the attorneys obviously are very involved in the investigations, and we always are trying to find ways to accelerate the pace of the pleading of the accusation and identifying for early involvement in high-stakes interim matters such as ISOs, well, interim suspension orders, mental and physical exams, Penal Code Section 23 bail recommendations where we appear at the criminal hearings. And at the same time, our attorneys are always keeping an eye out to close those meritless cases so that we can have the physician return to what they want to do with their lives, which is to serve patients and be doctors. And we try to get them out from the cloud of investigation as soon as possible. And of course, if any matters identified by Mr. Gomez's staff as a criminal case, we step out and focus on the ones that will lead to disciplinary issues that we can contend with. So luckily, there has been a continuity in the staffing, and that's the former medical board investigators and the current stock of deputy attorneys general, and we rely continuously on a daily basis on their respective passion for the mission, and they have allowed us to continue the course and continue the good work without too much change. So we're keeping focus from the Attorney General's perspective of documenting the information in a way that will not end up producing 3 sets of statistics, which I know you do not want. We do not want one set. We want one set for all the entities and one set of statistics that we can all agree upon. So I will remind the board that in July 1st, 2014, we put together some transmittal guidelines to our office, and those are intimately connected to how the Attorney General counts its cases, ages its cases, and these are accounting benchmarks that we've maintained over the past years. And I think what I heard earlier in the enforcement committee is that you want to compare apples to apples, so I'm remembering that. And I'll work with Mr. Gomez to advise as needed. I have opened the conversation with Mr. Gomez, executive staff, and Ms. Kirchmeier about what those benchmarks are going to be that are going to be discussed as badges for improvement when we have to report to the legislature in March of 2015. Or actually, Ms. Kirchmeier will have to report, but I want to make sure that we at least start talking about what benchmarks she wants from each of our respective offices. And like I said in my opening, I believe it's still too early to identify whether there have been any improvements, and I do ask for your patience during this transition period. But no matter what I want you to hear is that we will be held accountable together with Mr. Gomez to make sure that if comparisons are being made, the same yardstick is being used to measure our efficacy with how the medical board may have conducted its business previously. I will note that, like Mr. Gomez was pointing out, I do not enjoy the same access to information to medical board investigations like we did before, and that is due to the fact that I do not have an interface with the CAS system like I used to, and that interface with Breeze does not exist right now. Breeze has its own issues that I have to wait until those issues are resolved before I can even start to ask for a peek at some of those milestones. So like Mr. Gomez said, we're actively working on producing a vertical enforcement protocol pursuant to your request to do so. We're working through each and every proposal proffered by HQIU to ensure that while public protection is paramount, the proper legal process and other considerations continue unabated as before. And if we are successful, I know he's very optimistic about December, but well, that's what we'll shoot for. Yeah. In conclusion, there are many details left to tend, but we're working on them. And we're invigorated and working on joint investigations with new partners and listening to these proposals. The Attorney General has 56 attorneys statewide, compared with HQIU's 125 investigators. I want to remind you, as you look at how quickly we can turn over these cases, while the investigators may have an active caseload of 16 to 21 investigations, our DAGs have about 40 investigations, and to that you add about 20 administrative cases, 3 to 4 writs, petitions, Penal Code Section 23s, and for our most experienced staff, appeals. And so by our statistics, each DAG handles about 106 cases a year. And of course, every time they close one, they just get rewarded with more work like the rest of us. So they work very hard, and there is an active BCP that I've put together, and I am hoping to get more staffing so that we can continue the important work consistent with what your expectation is for the turnover of it. And so we look forward to providing more concrete information to you at our next meeting at the 6-month marker. And as always, if you have specific questions, I await Ms. Kirchmeyer's direction on those topics. And if you ever need me to be available in enforcement committee or in a sub-task force, we're there to help you and serve you. Thank you.
Thank you to the both of you for that report. Are there any questions or comments from the members on this joint report? I'll start from my left, if that's all right. Doctor?
Thank you. Mr. Gomez and Ms. Castro, thanks for coming, especially together. For Mr. Gomez, most important thing is I hope you're taking good care of our investigators. They're our people. We want you to remember that. So what I'm looking for is timelines. I think Ms. Castro mentioned something by next meeting. I want to know some timelines. When can you give us the numbers where we are, so that when we are summoned to the legislature, we have something to show in real numbers, not real information, not just the data. So that's why, if you can give us a little more how on the timeline, I would appreciate it.
Yeah, and I, Dr. Donadev, I took the message from Ms. Yaroslavsky at the Enforcement Committee meeting that is the wish that you would like, and I'm going to try to do that. At the same time, work with Gloria to make sure that we don't have, and with Kim Kirkmeyer, that we don't have 3 sets of numbers, that we need to be consistent in terms of what we're reporting under the enforcement standards, if you will, that she's measuring apples and I'm measuring oranges and you're measuring pineapples or whatever, because that's where the criticism is going to start, is that the team is not consistent with its reporting, and that's what we need to be consistent about and be mindful of, is that the public expects us to do that, and so will the legislature, and so that we have something for you.
Dr.
Accountability
Lewis?
factor.
Yes, thank you.
I carry around with me, not all the time, but once in a while I refer to these things. I think you might have handed out at a meeting. These are the vertical prosecution process after SB 304 and sort of the timelines. Okay, and they're very helpful. And I think I see in here a lot of connections between you two, which are potential, not roadblocks, but could potential delays. And I know Breeze isn't perfect. It will not be perfect like immediately. But I'd like to know in some future meeting what these potential back and forth delays could be, so when we send to you a case, and then final board decision, what took place, why did it take so many days? Because we're finally held accountable to that last day, you see, in the eyes of the public. But all the other stuff back and forth, they don't really see. So it would be helpful, at least for me and maybe other members, to know about those connections and visually. Do you think you could do that?
You mean report at it at the next meeting, or talk about it?
Next meeting or sometime in the future, but this is really helpful because I see a lot of, between DCA and AG's office, and I see a lot of stuff going back and forth, and I see all these potential potential roadblocks or delays, and I just want to know, where they are.
Right.
So when I see a final number, I can see, okay, well, it's going back and forth here, and does that make myself clear?
Oh, I know exactly, I
Yeah.
think, what you're getting at. And so where you see the marriage of the investigator and the DAG,
Yes.
that's where the direction comes through. And so we have a couple of points where the DAG is involved, and other points where they do their work and work their magic and do it how they know best. They're the cops. But at the same time, one of the first things that I think Mr. Gomez raised to my attention, and I was happy to hear it, is trying to shrink those days a little bit more where we can give them, and making sure that the direction's not jeopardized, that the investigators get to do their work how they see fit. And so I'm hoping that if we can achieve this protocol, this joint protocol, you will see something looking similar, but possibly with less days in between each of those junctures. And I think that that's a shared goal for both of our offices.
Yes, Dr. Lewis, I briefly mentioned that, in the process of this work group, much of the steps that you're seeing in that visual diagram is really what we're starting to follow and what we're starting to look at in terms of my understanding of what they need, their understanding of what I need or what we want at some juncture, and that's where we're starting to refine, if you will, what those barriers might be, road bumps or delays in the process itself, because it's a discovery, if you will, that when we start looking at how we can make it better, that is kind of a roadmap that we're using, but at the same time, we're starting to repave that road. We're starting to repave that process so that it is more definable, more understood, just not only by the investigator, but also back and forth between the team members and the medical consultants. Okay?
Okay, that's good. You see, at the very end of the day, it's the number of total days to get from point A to Z, and that's what people look at.
Right,
So that's my point.
nose to tail.
Yes,
bookends.
exactly.
Yes.
Thank you.
Dr. Kraus?
Mr. Gomez and Ms. Castro, thank you for your dedication to our common mission. Sometimes we forget that we all have the same common mission. The irony I feel trapped in is while I was joining the board, we were in the midst of this transition, and the medical board was under criticism, which seemed to have led to the transition of investigation to the DCA. And apart from that, potentially delaying things in transition, it's still the medical board which is on the line in terms of demonstrating that we're doing the job. But we seem to be doing the job with one hand tied behind our back. The other word that I'm sensitive to is I heard the word additional billing. And I remember, I think it was the intent of the legislature and the DCA and the medical board that in this transition, the medical board not necessarily be burdened with increased costs to get the job done. So I would hope that Ms. Kirkmeyer is informed as to what the additional charges are, and I would hope that this, recognizing that this has been thrust upon us rather than selected by us, that the DCA would be sharing in some responsibility for that additional billing.
And the additional billing that I was reporting on is only the legal services budget. And I want to remind the board, or actually, I don't know how many were here in 2006, but the last time we had a legal services budget increase was 2006. And that amounted to possibly the equivalent of maybe 6 bodies. We have not had any new staffing or any increases to the legal services budget. On the other hand, the flat rate, I can let Mr. Gomez address that, but that did happen, the flat rate from DCA for their billing for investigative services, right?
Well, by statute, we're not allowed to bill the medical board. Their budget came over intact, so there's no billing to the Medical Board of California by HQIU.
So let me ask a couple of questions here, because it sounds to me like you're trying your best to get along. You're trying your best to sit there and be nice to each other.
We are getting along. We're not trying our best.
They're being genuine.
But I'm not real sure how this is going forward. We have a March deadline, It's now November. We have a BREEZE program that I kept hearing from Mr. Gomez is just not allowing you guys to share information. So March is around the corner. My concern is, what are the similarities that are working out? What are the barriers? Where can we be of any assistance? Where will we not be blindsided? I'm concerned that it's, the difference today is that there's a different entity overseeing the investigators. But other than that, everything was, I thought, moving along. So now we've changed the diagram or the paradigm of how to do the work. I'm not quite sure, I'm not real clear on where the getting along to going along to get along and what should we know more about? I'm just worried that we're going to get blindsided here.
It's my belief that I don't think you're going to get blindsided because we're in the same train as you're on. I mean, I'm going to be held accountable. I'm going to be responsible for those investigations and working with Gloria in terms of our joint effort in terms of the vertical enforcement program. So we have not just a bona fide interest, we're going to have a reporting interest as well, along with Kim Kirkmeyer in terms of the work that we're doing. So the process is that we're working through. When I said December, I mean, I'm optimistic, but I think that whatever we do together, Kim and Gloria, that we have to make sure that report and that deadline of March, that we are approaching it soon, that we have something, whether it's in the paradigm of the past or the new configuration, if you will, of how we do business. That's what we're going to try to achieve, that we have something that is understandable and it is improved, and we can report it that way, that there is not going to be a blindsiding of the Medical Board of California, because I'm going to be there too.
What are we going to see in December? I hear December, I hear March. What is it we're going to see?
Well, March is the legislative report that is due. December is my projection that we'll have something completed, whether it's in draft or final document.
Can you tell me what that word "something" defines?
Well, it's a term, vertical manual versus
So we're talking manual, or we're talking about a vertical manual? Are we talking about numbers reported out? We're talking about the caseload? What are we talking about?
The manual has numbers and timelines. We're working on those timelines to reduce those and look at and examine, if you will, or analyze, what is the process and how we got there, how we established the original baseline in some of those turnaround times that we had in the original manual.
So thank you for those comments. I mean,
And may I?
briefly.
Yeah. What I heard you say, Mr. Yaroslavsky, is, am I missing something? Is there a paradigm, something about to do with the paradigm on how to do work? We are delayed by the fact that we don't have a joint manual as of July 1st. So that's the bottom line. We went ahead and had to have something in writing that acknowledged the new program. In the absence of that, and I know Mr. Gomez and Ms. Kirchmeyer were very busy, we were not able to accomplish a joint manual before July 1st. So we are behind schedule, okay? So I'll put that out on the table. Mr. Gomez is following the July 2011 VE manual and has added some other policies immediately, and we're following the July 2014. At the heart of it, we're still doing the work. Cases are still coming over. We're attending subject interviews. We are reviewing subpoenas for the investigators. We're doing everything we're supposed to be doing. Are we working out of the same playbook? No, we're not. But are we still committed to the outcomes? Yes, we are. Do we still feel like we have to be very efficient and hurry? Absolutely. So
thank you.
That's what I'll say about that.
Thank you. It's the board's, we assume positive intent in all aspects, but it is the board's, if I can speak on behalf of the board, it is our desire that whatever outstanding issues there may be, that they're resolved. Okay? Now, we leave it to the parties delegated under state law to bring closure so that there is the apples to apples that we've been discussing for the past 25 minutes. We'll know when our executive director gives her reports the status of those things, and when you give your reports. But March is approaching. It takes a month to review a report and circulate, so that's really February. That seems even closer than March. And, and, you know, we're a stakeholder here, and we want to provide assistance where appropriate. Thank you for that report, the both of you.
Thank you.
We'll now move to item 12. Ms. Castro, update from the Attorney General's office.
Thank you.
We,
So
as brief
I
as
wanted-
possible.
Absolutely. I will keep it very brief.
Thank
we
you.
have new hires in Sacramento. That office is now fully staffed. We're happy to report that we hired Mr. Damon Filson. He comes to us from DHCS. Former Fresno DA prosecutor Michael Brummel will be working in Fresno. Carolyn Sanin joins our office from the U.S. Attorney General's office. And Connie Broussard joins us as Supervising Deputy Attorney General in Sacramento. We had been without a supervisor there for quite some time, and now we have one. I just wanted to report on one case that it's being handled by DAG Edward Kim and SDAG E.A. Jones. This is the Lewis matter. On September 17, 2014, the California Supreme Court granted petitioner Alwyn Lewis a petition for review in front of them. And so the background of that case is that the appellate court had already ordered that NBC's access of Cure's data was not a serious invasion of a patient's privacy, even though there were no penalties in Cure's for unwarranted public disclosure. So that's the issue that is going to get litigated. And obviously, Cure's, in our opinion, advances a compelling interest in protecting the public against incompetent, impaired physicians. And if Dr. Lewis is successful in his petition before the Supreme Court, any judicial showing or good cause requirement is imposed prior to the medical board being able to use Cures as an investigative tool, we firmly believe that possibly more patient deaths could result. And so we're very concerned about it, and we will work our best to maintain the appellate court decision to protect patients from overdose and to be able to review Cures as an investigatory tool. Thank you.
If you might, Mr. Chairman, if she could just quickly brief the board that this came from a medical board case.
Yes.
Right, and I think Attorney Fenton is the one that represented the physician and is making a point of that access to Cures, which we're going to hear a presentation about, I guess, tomorrow, would constitute a violation of patient privacy because the board had to go and get some additional records to show the medical conditions and the prescribing, and all the prescribing, I believe, was done in another state.
Oh, no, well, he actually
Had
did
both.
prescribe here.
They prescribed here, but they filled them in Indiana and some other places and things.
I'm not as familiar with that as a fact.
Well, the difficulty is if the court does rule that it is a violation of privacy, then we're going to have serious problems in terms of being able to have physicians and others use Cures.
Right. In an investigation where, for example, a prescription bottle is found bearing a doctor's name, we would not be able to use that doctor's name on that bottle from the overdose patient to pull the Cures. We would have to, we couldn't even begin an investigation pretty much. I mean, we would be completely hobbled, in my opinion. This would thwart the intent of the Cure statute, as has been for quite some time, and it would not assist law enforcement and regulatory agencies in their efforts to control diversion of these dangerous drugs, and it would result in the abuse of controlled substances. So it is a very serious case, and November 17 is when the opening brief will be filed by Dr. Lewis, and so we will see what happens after that. It may be a year before we actually find out anything from the Supreme Court. Thank you.
Are there any further questions or comments from members of the board for Ms. Castro's report? Seeing none. Do I have to do comments from the phone?
Yeah, none.
It's just a report.
This is very clever because they're arguing that they'll validate prosecutions.
Are there any comments from the public from that report? It's no action item.
Got that information.
Any comments on the phone?
It's just,
I don't think so.
Oh, no comment.
I Thank you. We've completed our business for the day. We stand in adjournment until tomorrow, Friday, October 24th. We'll commence immediately at 9 a.m. Thank you, everyone.
Thank you.